Welcome to the Public Accounts Committee, 13th of February 2025. There has been a widespread perception that NHS Dentistry is in a state crisis with huge regional variations in access to dentistry. In 2024, the previous government has published its dental recovery plan aiming to increase the access to the NHS Dentistry by more than 1.5 million additional courses of treatment in 24/5. The NAO's report in November 24 found the plan was not on course to deliver these extra courses of treatment. Even if the target was reached, it would still be 2.6 million fewer treatments per year than the pre-pandemic levels. So today we will be examining the current levels of access to NHS dentistry, how the department and NHS England set up and monitored the dental recovery plan and plans to improve access to NHS dentistry and reform the dental contract. So to help us with all that, we're very pleased to have the Interim Permanent Secretary, Professor Sir Chris Whitty, with us. He, of course, is the Interim Permanent Secretary, as I've said, at the Department of Health and Social Care and Chief Medical Officer, as we know from our television screens. Sir Chris was Chief Scientific Advisor for DSC from January 2016 to August 2021. Jonathan Marron, CBE, you're over there, Jonathan, is the Director General for Primary Care and Health Prevention, Department of Health and Social Care. Prior to this, Jonathan was Director General at the Office for Health Improvement and Disparities at DHSC. For NHS England, we're pleased to see Amanda Pritchard back again, Chief Executive of the NHS England. Amanda's been Chief Executive since July 2021. And to my left is Ali Sparke, extreme left, yes, Director for Pharmacy, Optometry and Dentistry, NHS. Ali has been in this role since August 2021. And in between those two is Jonathan Wong. I hope I pronounced your name right, Jonathan? Jason Wong. I'm getting a new pair of specs. The lenses are ready for collection, and they're going to be bifocal, so I can read things and see you all at a distance. Jason Wong is the Chief Dental Officer of England. He's the NHS and Department of England Social Care. In this role, Jason represents the head of the dental profession in England. So a particularly warm welcome to Ali Sparke and Jason Wong, as this is their first time in front of this committee. Welcome, both of you. Welcome, all of you. So we will make a start, please. And I think I'm going to start by asking perhaps Professor Whitty, how do you like to be referred to?
However you wish, Joe. But most people call me either Chris informally or Professor Whitty formally.
Whichever committee members want. We've received a sort of fairly late notice, this letter of the 11th of February, informing us of an error in the calculations. I think perhaps we should start, if you would, perhaps you or Amanda would explain what the implication exactly is of this.
I can do it. Yes, I'm happy to take that, Chair, thank you. We wanted to be completely transparent with the committee, so as soon as we became aware that there was an issue with the modelling, we wanted to share that with you in advance of the hearing today. My colleagues can give more detail, but basically what has become clear is that in taking account of what the 200 million funding for the plan would buy, we've overstated the number of new patients that would cover, partly because there were some costs that weren't included and others that were included, and then that was compounded despite multiple Department of Health and NHS England reviews. In practice, two things worth noting. The first is the gap in funding to get to the number that was in the plan is about 33 million, so well within the scope of the underspend in the total dental budget. So it did not impact on the operational ability to deliver the new patient premium, and it wasn't something that was flowed through to systems when they were doing their allocation. So they got the right numbers, not the wrong numbers. But second point is it does not change the fact that this was not a successful plan.
Okay. Anna Dixon, do you want to examine that?
Yes. Obviously, the NAO report suggests that the wider modelling that was underpinning this plan was recognised back in March of last year, that there were sort of things that were not giving confidence. So it's obviously very disappointing that something as fundamental as the sort of costs and number of appointments was based on flawed analysis. So I suppose, firstly, what confidence do you have that the modelling capabilities in the support of any of your dental recovery work now and in the future is going to meet the basic standards that an analytical service within government should?
We've now designated the dental service as a business critical model. So that means we have additional resource but also quality assurance on anything that comes out of that model in future.
So why was there no quality assurance on it?
There was, it was a mistake. So I think we just have to hold our hands up. There were multiple people from both NHS England and the department that looked at these figures over a prolonged period of time and they did not spot it. And it is with apologies to the committee that this has come out so late in the day.
And do you also have to notify formally the National Statistician or any other actions that you'll be taking?
We formally notified the NAO and we'll take advice on whether we need to formally notify anybody else. I would just say the one reassurance is it actually has no material impact on either what was said in the plan or the ability or otherwise to deliver.
Is that because of the assumptions about the underspend?
Exactly right.
Okay.
Danny, do you want to come in?
Yeah, just briefly, I'm guesting today on behalf of the Department for Health.
I should have welcomed you. I'm really
no
sorry.
Problem. So
you are very
you did
welcome,
inform
Danny.
me, so thank you, Chair. As my colleague has mentioned, back in March last year, the Health Committee looked at dentistry, and it became clear to the committee at that point there were concerns about the modelling. The BDA and their evidence raised serious concerns about the modelling. So I wonder, based on the history of that concern, when was this designated a business critical, and when was extra quality assurance put in place? Is it now, or was it following concerns a year ago almost when the modelling was questioned?
Again, just transparently, it's now. So the NAO, I have to say, also didn't pick up that there was an error because I think it is so complicated.
The Health Select Committee, which I wasn't a member of at the time, but it is a respected committee of this place, heard concerns about the modelling, raised this concern formally in our inquiry. So it sounds like those concerns were true. They were put to the department and NHS England, but no action was taken. And actually, in response to the concerns, the minister at the time said, in fact, whilst the modelling might not be fully correct, we were under-promising and were likely to over-deliver even more. And that just simply isn't true, is it? As we've seen, you've under-delivered even on the poor modelling that you yourself had at the time.
Just to say again, we have had multiple people look at this and nobody has spotted it. So it was not that people were not going back and checking again. In fact, we did an FOI response, I think, in January of this year, which again, I'm afraid, repeated the same errors. So lots of people have looked at this, lots of people haven't spotted it.
The Health Committee and the BDA, the evidence we heard, did spot it, is
yes,
my point.
And
we were not listened to.
And I'm not defending the fact that we missed it at all. All I'm saying is multiple people at prompting from BDA and others looked at it again and didn't spot it. It has now become clear, so we just wanted to be completely transparent. In terms of the impact on delivery, though the size of the dental underspend last year meant there was actually more funding available in practice. So the fact that that wasn't included in the original model hasn't hampered people's ability to get on and deliver. So that is no defence in terms of the model, but is just... I wouldn't want the committee to think that that was part of the reason that this was an unsuccessful initiative. That wasn't the reason that this didn't work.
Yeah, I'd just put it to you, perhaps it suggests something else to reflect upon if Parliamentary Committee, the BDA, the industry representative group, raise concerns about modelling and quality assurance doesn't happen until an NAA report a year later re-highlights the issue. That might be a learning point to take away, but I'll leave it there. Thank you, Chair.
Thank you, Danny. Point very well made. Rachel Gilmore.
I'm astounded. I have people in my constituency who live in acute pain for months and sometimes years. When you're doing your work as a senior civil servant, do you bear those people in mind?
Is that to me? I'm not
Yes.
a civil servant.
Yes. Or whoever is. Yes.
Well, I suppose I am a civil servant. I think, to be clear, everybody on this side of the table, as indeed everyone on the committee, is extremely concerned about dentistry. This has been a problem which has been slowly getting worse since the early 1990s, to be clear. This is not a sudden recent problem. It's been steadily getting worse. All of us see the harrowing stories in the press. There was more yesterday, there have been all the way through. I'm a frontline clinician. All of us actually very much see patients very much in the front of things. And I think anybody looking at dentistry in the round over decades, so this is through multiple governments, would say that the NHS dental system is very weak and has got weaker over time. The most recent things that were the immediate things of the NAO are important and a demonstration of the fact that these are not easy fixes, actually. But what I think we would all say this is a problem, particularly for those who find it difficult to get dental services when they need them in states of emergency.
All more reason to have noted what the Health Select Committee and the BDA said a year ago.
Well, noting that Chief Medical Officer, which is my job at that stage, it's nothing to do with dentistry because we're fortunate to have a Chief Dental Officer, so I tend not to get involved in dentistry. But I don't think, and to be clear again on the point that the Chief Executive made, I'd say two things actually. I mean, firstly, the reason that there were problems with this initiative over the last year are actually unrelated to the modelling. In fact, if the modelling had caused us a problem, that would have been a good thing because it would have demonstrated we'd have overperformed compared to where the modelling took us. And actually what has happened is the system has underperformed. So in reality, the modelling is we technically absolutely must get modelling right. I fully accept the points that have been made, but I don't want people to draw a line of sight to then say the modelling is the reason there are either problems with dentistry or problems with the initiative that was being considered by the NAO, because in fact they would have occurred irrespective of the modelling. The modelling was in a sense to one side, but we wanted to be entirely transparent in our response to the committee once this has been identified.
Just to put it in context, Sir Chris, Rachel Gilmore, who represents Tiverton and Minehead, we have constituency figures, and at 382 courses per treatment per 1,000 people, she has the worst figures in the country. So she has a right to be thoroughly outraged, I think, by this whole matter. My constituency, the North Cotswolds, incidentally, is not far behind. So I think we will be coming to questions about inequalities around the regions. But it's not acceptable, I would suggest, that her figures are nearly half what the best figures, which is Clive's constituency. I just don't think it's fair that some constituencies are getting half the treatment at other constituencies.
I'm having to write 2, 3, 4 times to my local ICB, chasing NHS dental contracts that my dentists come into my surgery and say that they've been offered but can't get, and it's a disgrace.
Well, as I say, in a sense, I don't think there's any disagreement in anyone in this room about the points you've just made. My point about that was this has been a long-standing problem that has been there for decades and getting worse, and has got worse since the pandemic, no doubt about that at all. But this is not a sudden and new problem, and the disparities you've talked about have unfortunately been long-standing. So I think everyone should agree that the NHS dentistry is in a much weaker state than most other areas of the NHS, and I'm sure we'll come on to the reasons for that during this committee hearing.
I want to move on, but I'm going to come in at the top of the session before I bring in Anna Dixon, and I'm just going to quote you from the evidence we've received of the Association of Dental Groups, a well-respected body, I think, and they say quite clearly, and I want a yes/no answer from both you, Sir Chris, and Amanda, please. They say, based on the 2006 contract, currently the NHS dentistry contract is not fit for purpose it was developed for. It can no longer cover even 50% or less of the UK population it was designed for. Yes or no, Professor Chris, is it fit for purpose or not? Yes or no?
Asking someone like me for a yes or no, you're going to struggle. But the short version is I broadly agree with that.
That's all we need.
I don't agree with all in that.
That's all we need at the moment.
But broadly, I agree with
Amanda, Pritchard, yes or no?
Is the contract fit for purpose?
Yes.
No.
Brilliant. Well, at least we start from a common base, all of us. So that's really helpful. Thank you for that brief answers. Anna Dixon, please.
Thank you, Chair, and sorry I should have previously declared that my conflict of interest, that I previously worked as a civil servant in the Department of Health. So obviously today we're looking at the so-called Dental Recovery Plan, which when it was published in February 2024, under the previous government, set out some ambitious aims for additional 1.5 million treatments, equivalent to 2.5 million appointments. So are we on track to recover?
Well, I'll have a first go at that, and then others will want to join. But I mean, the very short version is no. Within the dental recovery plan, there were 4 components, of which I think one didn't start at all, which was on dental vans. Might want to come back to that, but it was on the smaller ones. Of the other 3, there were 3 elements which were aiming to address recognised problems. So the problems were real. Everyone, I think, would accept that, including dentists and people who look at this field. The solutions were unsuccessful. So the 3 problems that people were trying to address was, firstly, that the dentists would say, and the Chief Dental Officer, I'm sure, could give you better information on this, that the first appointment for a new patient takes longer and, or at least should take longer and be more complex, potentially, than for repeat patients. And yet there was no incentive for people to take on new patients. So there was a patient premium that was for a simple event for £15 and £50 for something which required greater measures. So the aim of that was to address a problem which had been identified by dentists as one of the reasons people were not taking on new patients in the NHS. The second issue was that there are areas of the country, and we've heard absolutely rightly, some areas are even worse than others, but there is no area of the country that is good on this, where there are particular lack of dentists. And therefore there was a scheme, which I'm going to loosely call the Golden Hello scheme, just because I think it makes it clear what it was, which was £20,000 premium given over 3 years to people to move to those areas. These were areas that had long periods of dentists being advertised but not being able to fill posts, and this was a way of trying to incentivise this. And the third one was that the minimum unit of dental activity, UDA, amount has now just separated a long way, and I think this is absolutely fundamental to why many of the problems exist, actually, from what a dentist would be able to make in the private sector, and it was to increase the minimum amount that would be actually paid in that to try and help remove this. It only applied to a relatively small number of practices, but it brought those ones up closer to, in a sense, the market median amount of money that people could make for voice. So the concept behind them all was theoretically entirely reasonable. And so of those, I would say one of them clearly failed, which was the new patient premium. Mm-hmm. And the reason we can say it failed was the expectation was that this would lead to an increase in people taking on new patients. Now, there was evidence of an increase in practice for a short period of time saying they would take on new patients, but if you look at the numbers, there is no evidence that there's any increase over what you'd expect over the following year. So I think we'd all accept that one did not work. On the Golden Hello, I think it started relatively late, and I think it's too early to say how effective that's going to be in the long term, but some people have come into areas that have been difficult to enter. So I think in that one I would give it a provisional let's see rather than an absolute fail. It had not achieved its goals by the time the NAO looked at it, but that was relatively early on, and these things take a period of time, so I wouldn't want to say anything. And on the UDA uplift, I think anybody who looks at the dental contract would agree that the gap between NHS UDAs and what someone would make in the private sector is part of the issue. So I think the logic behind that was a reasonable logic. But of course the most expensive of those was the one was the new patient premium. That was the one that was also expected to have the biggest impact, and I think you'd all accept that it did not. That's a statement of fact.
Thank you for explaining clearly and in lay terms the different elements of the plan, and I know that colleagues are going to come back to those. I suppose I was really thinking about the headline in terms of, you know, are we not on track to deliver the 1.5 million? And if we're not, how many additional courses of treatment have been delivered under the plan? That may be a question for you, Amanda, or colleagues.
Yeah, I can. Ali, I'm sure, can provide a bit more detail. But overall, as Sir Chris said, or Professor Whitty, sorry, I don't know I've forgotten which one we're going for today. But as my colleague said, we are clear that the new patient premium, which was the one that was designed to drive more activity, has not only not delivered that, but actually, as per the NAO's findings, we have actually seen fewer new patients this year. Overall, UDA activity is on track to be about 1% higher this year than last year. So that is in line with the sort of increases that we've seen over previous years. So that would not suggest that the impact of the measures has resulted in anything like the outcomes that were hoped for.
I'm trying to get a number in relation to the 1.5 million, I think is I haven't heard yet a sort of we've delivered X. Have we delivered any additional appointments?
I don't think we have evidence that we've delivered additional appointments yet in year. What we've seen is that we've seen 2.7 roughly million new patients coming through already, but that is on track with what we would have expected to see if this year's performance had been similar to last year's. In terms of the impact of the Golden Hellos and the £28, we need to look at the year-end data this year to look at the contracts affected to see whether those contracts in particular have seen an increase in performance, which is a small part of the 1.5 million. But I think it's too early to say that at this point in time. So I think we can't say at this point that we've delivered towards the 1.5 million.
Okay, and so in terms of recovery, so in terms of relative to pre-pandemic, some of the data suggests that there's still some 4.7 million fewer treatments going on than there were pre-pandemic. So we're still way off recovery, not least recognising that even before the pandemic, dentistry was in a parlous state.
I think that's correct. So we have seen levels of access across adults and children increase since the pandemic, but they're not yet at levels that we saw prior to the pandemic. So, for example, for adults, we saw, as of 2024, about 40% of adults in the previous 24 months. If you compare that to before the pandemic, it was more like 48, 49%. For children, 56% in the 12 months, because we measure it on a different time scale. Before the pandemic, that was 59%. So the access for children has recovered at a slightly quicker rate because we try to prioritise that. But it's absolutely true that the access overall has not recovered to those levels.
Yeah. Okay. And I suppose the other measure of this is the extent to which, I mean, as we said, pre-pandemic, only half of people are accessing anyway. So we may come on to some of the more fundamental issues and how they're going to be resolved with dentistry in general. But obviously we're also seeing dentists still continuing to opt out of NHS, reducing the number of NHS hours, and some of them giving up on NHS practice altogether. So on that, any recovery, or is that still going sort of in the same trajectory that it was pre the recovery plan?
So we actually have a similar number of dentists doing NHS activity than we had before the pandemic. It dropped slightly in 21-22 and it's climbed back up again. But I think the fundamental point you're making is correct, that on average, dentists who work in the NHS are spending slightly less of their time on NHS activity now and slightly more doing private work. And some of that is for some of the fundamental reasons I'm sure we'll come on to, which is to do with the attractiveness and otherwise the performance of the underlying contract. But there are also broader workforce issues that are playing out in different parts of the country. There are other sort of conditions to do with the amount of money we have at the moment. You've already mentioned that we have obviously enough roughly to cover 50% of the population, but we also aren't making the best use of that money in the most flexible way to enable money to be moved from, for example, underperforming contractors to higher performing contractors. We've taken some steps on that, which I'm really happy to go into, but those are some of the fundamental reasons why we're seeing some of the trends you're describing.
I'll leave it for colleagues perhaps to follow up on that point, but thank you, Ali. I'll hand back to the Chair. Yes.
Can I just follow up, Ali, please? In preparation for this hearing, I got a brief from the Gloucestershire ICB, and one of the things in that brief I think is absolutely shocking, and it's this: 16.8% of 5-year-old children in Gloucestershire have dental decay. I mean, this is storing up huge problems for the future, isn't it? So what more can be done to make sure that children, particularly young children, are either receiving the correct education via their parents to do something about this, but if that doesn't work, then in schools, and if that doesn't work, then in the health service system. So I don't mind which of you covers that, but it does.
Shall I have a first go at that,
Yeah.
Chair, and then others may want to add? And that's because prevention of dental decay is something which I have been heavily involved in over time. I think that essentially there are kind of three components to this. The first of which is trying to reduce the things which are likely to increase dental decay. Of those, probably the two most effective in broad terms actually are the sugar levy that was brought in for different reasons. It was aiming to address obesity, but there is clear evidence that that has led to a reduction. There was an inflection point, a reduction, I'll give you the numbers, I've got them in my notes if you want, in dental decay. And reducing sugar in the diet, all the way through the diet, really from the very first point children actually are weaned, is a critical part to reducing dental decay. The second component, which comes for older children but is important, is smoking. Smoking is a big risk factor for both dental disease and for gum disease. So again, actions which are happening in this House at the moment will in due course have a positive effect on older children's health. That's less true further on. And then the third thing in terms of that sort of more general stuff is extending water fluoridation, which we know leads to a significant reduction in dental decay, particularly in areas of relative deprivation. That evidence of that is around us from multiple environments. There's currently only 10% of the UK population has water fluoridation at the moment. That's much higher in most other countries, up to 80 or 90% in some countries. There's currently a consultation which the government is going to respond to, I hope, very soon for the North East and then look elsewhere. These are things which you can do across the board, which are really aiming to reduce caries and the dental damage in children in general. Then you come on to the specific actions, and there are things which parents and schools can help with, but the government can as well, of which supervised toothbrushing is probably the most important. The government, the current government, has put a lot of emphasis on that and is trying to work out ways to increase that. And then in a dental context, when people see dentists, fluoride varnish is also highly effective at protecting teeth. And then the third line of defence, of course, is going to the dentist and dentists dealing with things at an early stage of disease rather than waiting till teeth have got to the point where things are damaged, because it is a very sad reality that the commonest procedure that children go into hospital for is for extraction of teeth due to severe dental caries, which of course sets them up for lifelong poor dental health.
And costs the NHS a lot of money, because if you don't, we all know, we've had this time and time again in this committee, and it doesn't seem to be getting through. Prevention is cheaper than cure. And to give that answer that you've just given with all these things that we can do and this and fluoridation and that, and the bottom line is children need to have access to a dentist.
In a sense, both of the points you've made I completely agree with. Prevention is absolutely critical, because much better than having a small tooth decay, which a dentist deals with, is not to have one at all. So I totally agree on the prevention. And then I would also completely agree, all of us would agree, I'm sure that the chief dentist would firmly agree, that dentists being able to get to children at the earliest point and deal with problems early is critical. Jason, do you want to?
Yeah, I think I can follow up. I think with the 5-year-old children's statistics, you've got to really look at actually the culture of prevention back in home. We haven't really normalised those messages like we have with the rest of healthcare. Just simple twice a day, fluoride toothpaste and spit donors are not part of really our culture. So I think that the measures that there was a return on investment sort of measures, including water fluoridation, which came out top, supervised toothbrushing, as I said, is a focus, and also sort of focused toothpaste packs, and that those are work that is going on, that there is innovation going on where local authority will lead on that, where that is being focused on, and as I said, new government's manifesto pledge in terms of the supervised toothbrushing. There's also cultural and sort of demographic effects of that as well. It tends to map deprivation, and the impact tends to map deprivation as well. So the wider context needs to be taken into account. The impact in terms of the level of decay is also important. So, those the statistics that we all don't like seeing in terms of the extraction and the general anaesthetic and the tooth decay, that again, it's the impact and the inequalities. And one of the struggles really, how do you target that, as well as obviously access to dentists?
Can I give you a hint? Minehead, in my constituency, is 324th out of 324 on the social mobility scale. It is deprived. It also has the lowest amount of dentists in the country. Please, will you take that statistic away and try and do something about it? If it means talking to the Somerset ICB, that would be great, because I won't have to write to them for a fourth time. Thank you.
Thank you, Rachel Gilmore. So Professor Chris, the 10-year health plan must commit to reforming the dentistry contract, focusing on outcomes and incentivising prevention. Can we have your assurance that it will do that? This was evidence from the NHS Confederation.
Well, I'm going to be a bit cautious here, simply because obviously I'm not a minister, I'm an official. So what is in the 10-year plan is absolutely for ministers, but they have made clear that they want dentistry to be part of their plans. They fully recognise all the problems that are there. All the current ministers have made statements to that effect at various points. And if I could maybe read out something which came from Minister Kinnock, who is the minister who's responsible for this, what he wrote in the newspapers this week was, we're bringing forward fundamental change that can get the sector back on its feet, but the problems in front of us are increasingly evident. So his point, but I wanted to just read that out because it's his words that this is about
really
fundamental
helpful.
change.
So that fundamental change is going to hopefully involve more treatments by dentists. That inevitably is going to lead to more hospitalisation of dentistry. So shouldn't hospitalisation of dentistry be included in the whole dental programme?
I think probably the chief dentist would be a better person to answer that.
Yes, very happy to. Yes.
In terms of whether, I think dentistry is focused almost about 90-95% in primary care. That's where the delivery.
That's the point of the question. Shouldn't the treatment in hospital, which inevitably, if you're going to improve primary care, which I hope we will, that's the whole thrust of this hearing, if we improve primary care, it is going to put more pressure on dentistry in hospitals, so shouldn't that be included as well?
Yes, I think it should, although we've done quite a bit of work in moving quite a bit of hospital dentistry into Tier 2 services across the country, although, again, not consistently. It's more patchy across the country, but a lot of the treatment can be carried out via sort of enhanced services, and where practice can carry out Tier 2. And we've set frameworks for the Tier 2 accreditation so that can be done. But yes, it definitely needs to be taken into consideration, because whenever you have more access in the primary care, the referrals then will be generated.
Just to follow up on Alan Dixon's excellent questions, after all, she was a very senior civil servant and understands these issues. Amanda Pritchard, clearly the premium is the biggest part of the delivery of this whole system. What decision has been taken on its future?
The premium will end at the end of March.
What will replace it?
I should say it was always intended to be a one-year interim position, so it will end as intended. It hasn't worked, so at the moment there is no obvious logic in continuing it. The thing that we are focusing on next, which is a very clear priority for the government, is the delivery of the 700,000 additional urgent dental appointments. So we've been very clear in planning guidance, which has gone out recently, that we are expecting commissioners now to begin to plan for that. We have begun through Ali and Jason the engagement with commissioners to help them plan for that, and crucially we are learning the lessons of what hasn't worked. So one of the things that we will be doing this time is being very clear, as per planning guidance, that we are expecting local commissioners to commission additional activity. So not as part of the core contract, but additional activity. And we've got examples across the country of where some ICBs have done some very interesting and effective work on this. Manchester, the London hubs, Norfolk and Waveney, done it through existing practices taking on more work. We've got an interesting example in Suffolk, which is a partnership with a university. So there are models out there that we know work, including in some of the rural areas that are more challenged around access. And part of what we will be doing is then performance managing that through ICBs over the coming year.
That's all very well, but they need to be funded for it. And if you're in Rachel Gilmore or my constituency, the only way I suspect the ICBs can do that would be to take the money from somewhere else. So how will all these extra initiatives be carried out in areas like Rachel's and mine, which are already struggling with the costs on this?
Well, unfortunately, your areas are examples of where too much money is actually being returned to the NHS because it is not being spent on dentistry. So there is the funding there to do this work, but rather than expect it to be done as part of the core contract, we will be treating it differently because that is one of the big learnings from this.
But in the article in The Guardian today, the headline is that dentists are walking away from the NHS because actually it loses them money to work as a dentist in the NHS. So you can talk about modelling, you can talk about this, you can talk about that, but the basic facts are that dentists, with all the goodwill in the world, cannot afford to stay within the NHS, and they are walking away, and their membership body has told you that.
So, okay, Ali, sorry.
Well, sorry, if it's okay, just to come in briefly, because
Yes,
I think it's a really important point. So I think a lot of the experience that we have seen over the last year from ICBs who are starting to commission additional urgent care activity, it's not through the core contract. It is through additional sessions, often additional appointments commissioned via different routes. And that is really important because I think we accept your fundamental point, which is that the core contract isn't working for urgent care properly at the moment. It's not differentially remunerating the amount of care that patients need, and it doesn't set a core capacity that each practice needs to deliver. So what we're trying to do is build on a lot of the good work that has been in place in different parts of the country, certainly in the places where access is poorest, and I think your constituency amongst them. There is, we've put a ring fence in place again for this year, which means that dental funding is protected, and that means that the money that they know they won't be able to spend on some of the contracts for the underlying reasons you're describing will be available to commission these additional services, which won't suffer from the same problems as the core contract has, which is one of the reasons why we're not seeing the delivery.
Well, just to follow that up, let's go to paragraph 1.19 in the NAO report. There are 34,520 dentists registered with the GDC, of which only 24,193 are providing some NHS dental care, and that figure is dropped by 483 since 2019-20. Ms Gilmore's right. Unless you incentivise dentists properly, they won't be there to treat people. So what is the fundamental thinking within NHS, the department, that is going to change that? How are you going to change the culture of dentists to want to provide NHS treatment?
When it doesn't lose them money.
That's what I'm going to come on to.
So it's an absolutely fundamental point, and I think a couple of things to say. So the first thing is that we're talking today predominantly about the dental recovery plan. I think it's important to be clear that that plan and the new patient premium, as an example within it, were not intended to address the underlying issues that you are both describing that are affecting some of the issues that are facing constituents in your areas. We've known for some time, and indeed we started a programme of reform in 2022, which made some initial changes to start to help move the dial on some of the things that dentists were telling us. We've known and recognised even since that point, and in fact it was a commitment in the plan last year and under the previous administration, that further reform is absolutely fundamental to changing the incentives and making sure that dentistry remains attractive to NHS dentists. We've worked quite hard over the last year and a half to look at a number of different themes, and we've got an understanding, and I'm really happy to go into a bit more detail if it's useful to the panel, about what some of the core issues are that we would need to tackle, and the ideas that we've started to develop to address some of the issues that we're seeing, and a couple of which we've touched on.
We may well
already.
want to come back to it because this is so fundamental, but we've got a lot to
Sure.
cover. So let's see where we get to and see where we're going to come back. But thank you, Ms Gilmore, for that
thank you,
really
Geoffrey.
important question. Anna Dixon.
So I'd like to move on to another of the elements in the recovery plan, which is the uplift in the UDA. I should say units of dental activity for the record, but I will refer to them as UDA. So obviously this was set at £28. I presume with the hope that this would better compensate dentists. What analysis have you taken of the impact of the uplift in the UDA? And I'm looking to see who to address this to.
So I think it does come back to the conversation I think we had a bit earlier, which is that we are still in the first year of seeing the impact of that uplift. So it affected roughly 850 or so contractors. And obviously to different degrees. We did have a minimum UDA value in place before it was established for the first time in 2022. We had some evidence from the previous analysis that raising the UDA value was associated with slight improvements in activity, not least though for the reasons Professor Chris said earlier on. It was the right thing to do given the huge range of prices that we were paying dentists for the same activity. So we will see. It's too early to say definitively what impact that has made. The qualitative, the anecdotal feedback so far has been important in supporting the sustainability of those practices, but we will see more quantitative data once we look at the activity over the full year. So we'll know that at some point in early 2025.
Well, sorry, Anna, could I just come in here? I'm really sorry to interrupt you, but I'd just like to get your reaction while we're on UDAs, and Ms Dixon quite rightly raised it. The NHS Confederation told us in evidence the UDA system fails to consider the complexity and cost of the treatments provided, e.g. a simple filling that costs 3 UDAs is reimbursed the same amount as a more complex treatment involving 5 fillings, a root canal and an extraction, also costing 3 UDAs. So it's not only the amount, it's the structure within what they're supposed to cover that is a problem. Now, I don't know which of you wants to cover that.
So, Chair, shall I have a first go at it? Because I think the danger is we get into the weeds, and then I think we can then get into more of the detail, which I think is really important.
Yeah.
I think, firstly, one of the fundamental points, and without necessarily just automatically accepting that the British Dental Association, which is a union just like the British Medical Association, is saying, I'm not going to accept all their numbers as the correct numbers, I'm not commenting on them one way or the other. But the general principle is that if you went back to the early 1990s, the number of, if just taking the things, 90% of dentists were getting 2/3 or more of their income from NHS work. Now, what has happened since then, and Dr. Wong can probably give more details on this, is that the gap between NHS work and private work has started to widen. And additionally, there are a number of things which are available in the private sector which are not available, particularly cosmetic, in NHS care. So a dentist, perfectly reasonably, this is not a criticism of dentists, this is a perfectly reasonable position. A dentist is now essentially faced with a much higher financial incentive to go down private routes in many situations than to go down the public routes. That's the fundamental problem as far as I can see it. Now, within that, and this goes directly to your question, the structure of the dental contract has been a disincentive to do some of the more complex work. And there was a reform in 2022, which I think was the first reform since 2006, which actually made a useful difference. And it did split what was called Band 2. I am now going to the weeds. Band 2, which really was from a relatively simple procedure to a complex procedure, into 3 subcomponents, recognising that more complex things, of course, took more time and therefore should be remunerated on a scale that was commensurate with the additional time they took. Now, what was clear was that was a step in the right direction, but what it didn't do, and has not done, is fundamentally deal with that first issue, that the gap between, in a very mixed economy compared to other bits in the NHS, the gap between private provision and NHS provision is there, and most dentists do both. So they have, in a sense, they have a choice. I'm
really sorry, I just want to come back on this. This was a rather long-winded answer. but there's a fundamental question here which I raised earlier. It's no good addressing the world of dentistry as we might like it to be. We have to address it as it is. And the fact is that finite number that I just given, the 34,000 odd dentists, have to be properly remunerated, otherwise they will increasingly go to the private sector. Are we agreed at least on that as a basis?
You've put rather more concisely what I said, trying to put a bit of technical detail underneath it, so I agree with that point.
Good. Right. Anna Dixon.
Yeah, and I'd like to carry on probing around the way that we're currently paying for dental care. And I was also going to quote the NHS Confederation, who say the current NHS dental payment system based on UDAs has led to inefficiencies in both care delivery and budget allocation, with many dental practices avoiding NHS work due to uncompetitive rates. And this has resulted in underspending on dental budgets locally and poor access to care for patients, particularly in the most deprived areas. And, you know, the Nuffield Trust, independent, respected, also saying that this model inherently fails to recognise variable patient complexity, disincentivising treatment of those greatest needs. So it's not only, though, about the differential in price between the private and the NHS sector. They're actually losing money on some of these procedures. So suggests that for dentures, they might be losing as much as £42.60. And I guess this is why one of my constituents, Graham, who needed to go to a dentist to get new dentures fitted, and as a result lost weight, was finding it difficult to eat, basically was faced with very, very long waiting lists to get access to NHS dentistry, which was obviously having a very significant detrimental impact on his health. So he actually got the problem solved through a referral to a community dental team, which I assume is completely out with this sort of usual general dental practice contract model. So thankfully, he has managed to get an expedited health appointment. But that's sort of getting round what is otherwise a broken system. So sort of coming back to this point, really, okay, we may agree that the UDA is not properly recompensing. So why did you think that uplifting it to just £28 was actually going to have any impact? It seems to me we've received local examples where, you know, they've tried £30, you know, why not £35? I mean, was this a question of cost? What was the... I'm trying to really get at what you thought the £28 was going to achieve.
So I think the distinction you're drawing is a really important one between the absolute value associated with a UDA for any one particular practice, and then the amount of UDAs we then pay for the care that is delivered. Yes. So both are real issues, and they both need separate remedies. So the first issue is about making sure that there is at least a minimum amount of income available for a practice that's not disadvantaged for doing a checkup, for which another practice will be paid a significant amount more. So that's why we've raised the minimum UDA value. But that is not the whole answer. The next step is exactly what we started to do in 2022, but we have to go a lot further, which is to differentiate, exactly as Professor Chris said, in a much clearer way, so that the types of patients for whom it's not attractive to treat on the NHS, that type of treatment is absolutely better funded and better incentivised. And that means creating further distinctions and making more funding available for those people who need it most. And that does require us making more significant changes to those remuneration mechanisms than we've already done.
Yeah, so obviously one is, and there's lots of suggestions, and I'm sure we're going to come back onto this, about dental contract reform. Or should we just be ditching that and recognising that these sort of, we need to just directly commission these sort of community-based health? I mean, would that not be better value for money ultimately, and a quicker remedy than doing some of these things which obviously have not resulted in getting better access for the patients who most need it?
I mean, Dr. Wong may want to come in a little bit on the community issue. I think it's important to point out that community dental services provide a very distinct function within the system we have at the moment. It complements the access we have for primary care, but is focused on particularly vulnerable groups. And so there is a different mechanism, there's a different set of provision that exists for those patients. So I think we absolutely need to get both right, but I don't think one is a replacement for the other.
When poor people in deprived areas can't get registered and
Yes.
can't be seen on the NHS, do they not become effectively vulnerable patients because they cannot get routine dental care or can't afford it privately? So I mean, maybe you would like to ask this, Mr. Wong, because it seems that those community dental services and also urgent dental care are picking up where due to the failure in primary care.
Actually, to quote your own words back to you, which I can't believe I'm going to have to say this and repeat it, patients that it is not attractive to treat on the NHS. That's what you said. Patients that it is not attractive to treat on the NHS. What a shocking statement.
Coming back to the community services, so they tend to be targeted at special care services, pain anxiety management. As a model, I think what you're talking about is, do we directly commission and hold the whole contract for the whole team and do it a different way? I don't think the evidence suggests that in terms of direct costing that would actually make it affordable in terms of giving wholesale care. Absolutely, in terms of priorities, and that's what effectively we've been looking at. Those specific commissions, like what's been considered for urgent care and what has been done in many areas for urgent care, have relied more on that kind of setup for providing care. And in fact, during the pandemic, it was a model that we used. But I don't think that although the fiscal part's not for me, but my understanding is that if you were to wholesale hold that contract, pay all the staff and have all that's a model that would be in some way better than what you managed to get. Although understanding access is the issue here. And certainly I think in certain localities and some of your constituencies in those where the workforce is particularly challenged, I think that is something that needs to be considered. But as a wholesale system change, I'm not sure that the
I guess that's a question about value for money. I mean, we're probably spending far too little, given that most people are not even getting any access. And so the question is, what from here, from a very broken system, is the most cost-effective route to getting the people who really need it access? And I suppose we'll come back to this. Chair.
No, I think that's the most important point of all in this entire session. Wouldn't it be better to rip the whole thing up and start again, have a consultation, talk to the dentists first to see what they need, and then try and redesign a new system that actually works? Because we're still spending a terrific amount of money, 3.3 billion on dentistry, and yet we're not succeeding. So wouldn't it be better to start again?
Can I have a first go at that?
Yes, of course.
Thank you. So I think the short answer to your question is that's exactly what we're going to need to do. And if I just say sort of three things, so just talking about today's hearing, what the plan was that we're discussing, which I think we would all accept has not delivered the outcomes, was an attempt, I think, in a sincere attempt to address some of the known problems within the existing contractual framework. There is a set of things that I think we've begun to discuss, which could be amendments to the existing contract. Indeed, there are live discussions with ministers at the moment about all of the things that we've discussed that would, I think, both go some way to addressing some of the really obvious problems. And we're keen, as I know ministers are, to explore that properly. But the right answer, I think, is to consider a much more radical reshaping of dentistry in this country, because it, I think, feels to us that sort of tweaking around the edges, which is ultimately what we're talking about, going back to the 2022 reforms, we can see that it has made some difference, but not enough.
So I have an absolute plea to you. That's a very candid, honest answer, but if you are going to move to a brand new system, we know from these Public Accounts Committee hearings, this takes time.
Yes.
And I think on behalf of our constituents, who are the people who are really suffering all this, what we need is a proper transition plan so they don't suffer further.
Yeah.
So talk to the dentists, talk to the people on the ground. You cannot do this without...
I made that point. Thank you.
Sorry?
Yeah.
So completely agree. And that's why I think what I was saying earlier is we are, again, keen to do two things in the short term. One is make sure that we have really learned the lessons of this attempt to make tweaks that hasn't worked. So as we think about the urgent access challenge for next year, which we're really focused on now. We're doing it in a different way that's more likely to be successful. And as I say, part of that is commissioning specific enhanced services for urgent access rather than baking it into the contract. But the second is where shorter term, we can make those tweaks to the contract to address some of the issues we've been talking about today. Again, with Minister support, we're keen to do that because otherwise, you're absolutely right, we could end up spending too long before we get to a place where we're in a much better shape. Can I add, the other thing that I think we don't want to wait on is workforce. So we had a commitment in the long-term workforce plan to increase training by 40% over the course of the next few years, starting in 28-29. The government's made a commitment to review the long-term workforce plan in line with the 10-year plan. But given what Professor Whitty said earlier, I think it is our expectation that dentistry will still be an important part of that. So both seriously thinking about how we improve the supply of dentists, and then secondly, and I think this goes to some of the points that we were talking about earlier, for those colleagues who are doing some NHS dental work but not as much as maybe they used to, we are keen to make sure they feel part of the NHS family, because one of the things dentists, I was at a dental practice last week talking to colleagues there, is they don't feel part of the NHS in the same way as many other colleagues do. So one of the things that we are going to do is make sure, for example, every single ICB has a chief dental officer or a lead clinician for dentistry, whose job will partly be to run the dental network, or not the official dental network, but will be to pull together colleagues, not just dentists, but the wider oral health team, so that they are actually supported properly in their roles.
Bring that together? The Association of Dental Groups tell us the dental workforce gap. Currently, there are 2,749 NHS vacancies for general dentists, 1,161 NHS dental nurse vacancies, and 497 NH trainee dental nurse vacancies. And many of these roles remain unfilled after being advertised for 180 days. So does that answer encompass the entire dental workforce?
So I'll let Jason come in a second, but I think my headline point would be we have to train more dentists.
It isn't just dentists, though. I've just illustrated it's the entire professional family.
Exactly right, and members of the oral dental team. That's the only really long-term solution here. But in the meantime, I think there are, and I don't want to overclaim for them, but incremental things that will help, making people feel more valued as part of the NHS is one. We do need to let the golden hellos keep going to see if they can give us some benefit over time, or greater benefit over time. We do need to make sure that members of the oral health team are able to work at the top of their licence. We've begun to see some movement on that, but it's still early days. And then I think there are some initiatives, again, around, for example, international trained dentists that, again, are making a contribution, but I wouldn't want to overclaim for the numbers on any of those.
Okay.
Can I just add one point to Amanda's, which is the number of dentists has actually gone up. The number of dentists doing NHS work has gone down. So it's not purely just a number of dentists question. It is actually to do with how many are actually going into the NHS.
No, I agree with that. Danny Beals, and again, warm welcome from the Health and Select Committee.
Thank you. I mean, we're dancing around the issue a bit, but I think you kind of bring it back to the kind of the attractiveness of private work. But is it not the unattractiveness of NHS work that is the fundamental issue? And cross-subsidy in primary care is not a new thing. Pharmacy colleagues would say the same, optometry would say the same, that relatively the value of their NHS work has not kept pace with cost, the real costs, and they cross-subsidise usually that work with private work, which has expanded, and in dentistry it seems to have reached a very critical point where even that isn't sustainable. So I want to come back to the kind of UDA. Fundamentally, do we not just need to look at what the actual real terms costs are of dentistry, and what the then UDA rates and relative extra payments are for more complex rates, if we do, what modelling has informed your current UDA rate, and what modelling will you be doing about actual costs of providing dentistry to inform the future contract?
Yeah, so I think we should be upfront and say that the current UDA rates were set a very long time ago. So back in 2006, as the new contract was at that point was put in place. And I don't think any of us around this table would argue that those rates are fit for purpose now. There have been flexibilities, and we made really clear and have been supporting ICBs over the last 3 years that there are flexibilities to change UDA rates within contracts that already exist, and ICBs have been absolutely making use of those flexibilities.
They are, because their local system isn't sustainable, so they realise that, so they're using their money to try and sustain the system.
That's right, they're trying to support practices that are really struggling. I think this does come down to the fundamental question of how much it does cost to treat different groups of patients. And I think it's true, and it comes back to my comment earlier on, which you picked up on, which is that those patients with the highest need obviously cost the most. That differential in dentistry is bigger, I think, than it is in general practice or pharmacy.
So I guess my question, sorry, because time is tight.
Yeah.
What modelling informed the £28 rate, and what modelling are you doing to understand the actual costs of providing dentistry? Yes, for complex patients, but for general patient, the general populations too. Like, what modelling have you done?
Evidence.
And what modelling will you do to inform what rates people actually need to earn to sustain NHS care?
Okay, so very, very briefly, also on the £28, and I think the NO report drew attention to this, that we looked at the relationship between UDA rates and delivery, and we made the decision on how far we could lift the rate with the expectation that we would be able to see better, more sustainable practices.
That's not modelling related to the costs. That's modelling related
that's right.
to
It was,
what might drive more activity.
Yes, that's correct. So there wasn't modelling related to the costs. It was based on that relationship that we looked at. In terms of the next steps and the things we've described already, we absolutely got a model that we're working on, and that's where Amanda's comment about the this becoming part of a much more assured process between us and the department. Those are the conversations we're having at the moment with the government about how we make the case for the different types of remuneration that we think is required under the contract. So that modelling.
So are you committed to actually, because you haven't, as you've highlighted, you haven't done that previously, are you committed to actually modelling what the costs of dentistry are in 2025, and going forward, actually looking at the actual cost of dentistry, not just what incentives might lead to some more activity?
Yes, we are looking absolutely at what we think is absolutely required for a patient as part of the course of treatment, how much that costs, in order to then inform the rates we think that
Will you be engaging the BDA and industry players in that modelling?
Yes, and indeed we've already had conversations with the BDA and the ADG and about some of these early ideas, and they're drawn from conversations that we've had across the profession, not just dentists, but also therapists, hygienists and nurses over the past 18 months.
It's also important to get modelling right based on the modelling failures previously.
Yeah.
Thank you.
We heard at the beginning of the session. Thank you very much, Danny Beals. Lloyd Hatton, you've been very patiently sitting there.
Thank you, Chair. I mean, as we're sort of dissecting the different parts of the recovery plan, so I wanted to touch on the Golden Hello scheme. Could you just, to start with, let us know how many dentists, as of today, have been appointed with the Golden Hello scheme, and can you give us an idea about where they are working? Obviously, at the time of the NAO report's publication, that number was just 1, so it would be really helpful for the committee to get a more accurate figure today.
As of today, it's 39, and there are, I think, 246 posts that are out to advert that have a Golden Hello attached to them. I think it's fair to say this had a slightly slower start than we had hoped, because the actual agreement of where the posts were that were eligible for the Golden Hello took longer than we had hoped it would. But it has now kicked off, and I think, as Ali said earlier, we would expect to need probably just another few months to see whether those posts that are out to advert actually convert into recruited dentists, or whether we end up, as the Chair mentioned earlier on, having just long-term vacancies, and we'll find that hasn't delivered what we'd hoped.
And then what is the long-term sustainability of the Golden Hello scheme? Having taken into account that we've gone from 1 to 39, how much longer do we want this scheme to run, and what do we see as a success story? How many appointments would we like to see?
Well, I'll let Ali come in on the detail, but at the moment, our view is that we do need to let this one run for longer, so not like the new patient premium, where I think we're all very clear it needs to end at the end of March. Golden Hellos, there isn't an end date. We'd want it to run longer to see whether it is going to generate benefit.
What will success look like in terms
well, the
of the
original
number of
aim was
appointments?
240 posts.
Yes,
That was what was in the original plan. We've got more than that have actually been approved to go out to advert, but we'd be looking at clearly getting to at least the 240 in order to be confident that this had delivered what we'd hoped.
Okay, as it stands, not a single dentist practice in my constituency is taking on any new adult NHS patients. One of my constituents, a sergeant stationed in a camp, has said he's unable to get himself registered or his wife or his 3 children, despite serving in the armed forces. So how can you ensure my constituents that these Golden Hello dentists are being appointed to where they are most needed? Because in my constituency, it feels like they're absolutely nowhere to be found.
So I think there's a couple of things to say. So the first is that obviously we've relied in part on ICBs to make sure they are working with practices where there's a long-term vacancy in place. That's one of the criteria for being able to be eligible for a Golden Hello under this national scheme. There are local variations of this, and it may be, and we can look at this. Your ICB is doing other work in this area as well, but the Golden Hellos are therefore designed for particular practices in particular areas where there's real issues with recruitment. If the practices you're describing and the issues your constituents are facing are to do with the fact that there actually just isn't enough dentistry commissioned full stop in your constituency, that does come down to a question back to the original point, which is we know that there is only enough funding for 50% of the population, and so our job and obviously the wider funding available for dentistry isn't my role, but our job is to make sure that that funding is absolutely prioritised for the people who need it most. And that's why some of the changes that we have described and the urgent care work that we're doing is about making sure that there is at least a safety net and access there for the people who really need it. So I guess there's a couple of different answers to that question.
I suppose my concern is that my constituent, who, like I said, is a sergeant stationed at Bovington Army Camp in Dorset, that is an area where the kind of problems that this scheme is meant to address exist. So there is a vacancy. There are vacancies for NHS dentists that go unfilled for a very, very long time, and it is a rural area. So when that becomes a problem, you really feel it because the next nearest dentist might be a very long way away. Yeah. So again, if we could go and drill into a bit more detail about how can we ensure that these Golden Hello dentist appointments, which there is an aspiration to go further on, actually reach constituents like mine at Bovington Camp.
Yes. So I don't know whether your particular practices in your area have already been given permission to advertise a post with the additional incentive attached. But that is, as you say, that those are exactly the kinds of practices that the scheme is intended to address. Yeah.
I wonder, Chair, should we write to you with detail of which practices have attracted the Golden Hello posts?
Would act
how
as an
the scheme
incentive.
works, yes.
Yeah. And why don't we explain what the allocation process
Would be really
was
helpful.
as well?
Thank you.
And just getting that clarity that they are actually going to where the need is most acute. You had obviously offered us reassurance today, but some further clarity there would be appreciated. Just finally on this point of the Golden Hello scheme, obviously as has been touched on by members here today, dentistry has been in crisis for many years. This policy was announced in February of last year when over 60% of my constituents did have to wait more than 2 years to see a dentist. So why did it take until October to appoint the first dentist via the Golden Hello scheme? And why are we now only at 39 now? It does feel like that the rollout has been quite slow. And what lessons are we going to learn from that slow rollout as we seek to reach a much higher figure that you've told us today?
Ali, do you want to go?
Well, so I think we accept the rollout was slow. We were ready to start rolling with the allocations out to regions at the time of the plan, but unfortunately it took a little bit longer for us to finalise conversations with government at the time around the exact distribution of posts and targets, therefore, to different parts of the country. We published the scheme in May. It was always our expectation that it would take around 6 months or so for the different stages to need to complete before people would come into post. So we are around that point now, following the publication in the early summer. So it's our expectation that we'll be translating and converting the offers now and the approved posts into roles as quickly as possible over the next couple of months. But we're also not where we wanted to be. We wanted to be at this point a couple of months ago.
Yeah. I mean, if I can add, I think we've spent more time trying to make sure that the golden hellos are going to the places of most need than perhaps we first thought we would need to. So that's why it's taken longer.
Okay,
it's about trying to get it targeted properly.
Can I just come in here? Is this going to resolve the regional disparity? Now, I don't in any way begrudge Clive Betts sitting next to me, but he has the highest number of courses.
Well, no, Sheffield does. There are differences in Sheffield.
All right, okay, but
Sheffield
Sheffield South East in your constituency has 800, and I'm not begrudging you that. But poor Rachel Gilmore over here only has 382. I mean, that is a shocking regional disparity, and it's what can be done to start to address that, Amanda? Please.
So Geoffrey, could I just say, it's not just that it's a shocking regional disparity, but it's also shocking that my constituency, the most deprived in the country, has the lowest number of dentists. So it's not just the regional disparity, it's the social economic disparity. I'm trying not to explode.
Okay, you made the point really powerfully. Amanda Pritchard, would you like to just answer that, please?
So can I start by saying that I agree that it is a shocking regional disparity, and I think that is two primary things that are driving that. One we've begun to talk about, which is workforce, because we do not have enough dental practices doing enough NHS work in the places which are least well served. The South West is a particular problem area. The second is, and I think we touched on this earlier, Ms Dixon's comments about local commissioning practice, because even where we have got areas which have fewer dentists, we are seeing now increasingly some ICBs coming up with much more creative solutions. We've referenced some already. Suffolk might be worth calling out. They've got a partnership with a local university, so they're doing something that is about training into practice as a social enterprise model. There are universities, there are dental schools in the south, so it may well be that actually there are some of those things, the early days, again, in terms of the ICB's maturity and setting up some of those new arrangements, but that would be applicable and would work well in areas where there's currently under provision. So I think we have to do two things. We have to keep going on what it's going to take to make, this is, by the way, in addition to the points we've made about the contract in itself, but make it more attractive for dentists to work in the places where we currently have less provision. And we have, and this is one of the things we take very seriously, working with local commissioners, because it is now a delegated service, both to share best practice, but more than that, actually to hold people to account then for following through on implementing that locally.
Thank you very much, Amanda Pritchard. We like innovation in this committee, so I'm hopeful that Lloyd Hatton is going to ask us about a bit of innovation.
Yes, so I'd like to move on to another segment of the recovery plan, which was the idea of dental vans, which were specifically to deal with sort of rural coastal areas where there perhaps isn't actually the infrastructure in place to appoint dentists to, and actually these vans would help to plug that gap and to drive up health outcomes in those areas. As far as I'm aware, this report makes clear that no dental vans have been procured, and the issue of procuring dental vans has essentially now been handed down to individual ICBs across the country. My ICB, NHS Dorset, is on a list of expressing an interest, but as far as I'm aware, there hasn't been any procurement going on. So I suppose what would be helpful is if you could identify which, if any, ICBs have actually gone ahead and procured these dental vans.
The first go on the dental vans. I mean, firstly, there already are dental vans obviously in the system. There are probably around 20. Some of them are not in the NHS, some of them are in charities. They tend to be in areas either of considerable remoteness and rurality, or for very specific groups. So, for example, for homeless people in London might be an example. It's quite an expensive way to provide the same level of service, and it's quite labour intensive. So the number of people who can go through a dental van per day is lower than would be true for a normal dental practice. So there are some difficulties, and I think notably Some of the dental vans that are currently in place are now termed static, i.e. basically they are stationary, although they are providing dental services, implying the vanness of them actually hasn't provided enormous help. The view of previous ministers in the last government was they wanted to have a national scheme on increasing the number of dental vans. Ministers, when they came into the new government, really wanted to have that as a delegated decision down to ICB. Yeah. So that's what happened, and to date, no ICB has said actually they wish to invest in a dental van at this point.
My understanding is it looked like there was a bit of a disagreement between ministers in the previous government and NHS England as to whether or not dental vans did actually provide good value for money. So, Amanda, if you could touch upon, is that your understanding that actually ministers wanted this, but there was very little in terms of a value for money argument to defend procuring these vans?
I might let Ali talk to the detail of this, but overall, certainly, I think we were quite clear that as Professor Whitty, I get it right, as Professor Whitty says, that there can be a really useful role for dental vans, and they are in use for some very targeted purposes, but what they are not is a replacement for a well-established dental practice that provides comprehensive care. So that was the discussion we had with the previous government. But Ali, perhaps you'd like to add some detail.
Yeah, I mean, I think that, yes, as an overall point, I think we were absolutely concerned that as a catch-all solution for a range of ICBs to be imposed on them, it didn't feel like it would guarantee there being good value for money of that. Not least because for many ICBs, if that required them to purchase a new van or lease a new van, that could have very high start-up costs. And clearly, ICBs have really important priorities around thinking through what their other options are for their most vulnerable populations, and some of those initiatives didn't involve the use of a van, and where that was the case, we obviously supported them to do that instead. And I think of the points that Professor Chris has made around the vans just don't offer a comprehensive service. Yeah. They're very expensive. There's lots of things you cannot do from a van. They often require a patient to be followed up in another place anyway. I completely appreciate the point of the vans wasn't to sort of fix all of our problems. It was to address a very specific problem for a very specific demographic. It seems that there is a consensus here that perhaps the policy of vans sort of pursued by ministers in the previous government did not provide particularly good value for money. So why was this taken forward? Or was this a case of where they just wanted to be seen to be doing something, but actually it wasn't actually going to deliver the additional appointments and the additional treatment that we needed to see for patients?
Well, leaving aside the fact that we would be very, very cautious to criticise past ministers as we would to criticise current ministers, I think that the point about dental vans is that they have an important niche. So, for example, dental vans in Devon look at the dental needs of people working in the fishing industry because they find it very difficult to access services. So none of us think that there is no role for dental vans. I think the real question is what is the specific niche in a particular area, and that's why the decision was rather than it wasn't to say don't do dental vans under the new government, rather it was to say ICBs who know their own patch can know is there a niche for which this is an effective way to provide dental services or not, rather than trying to direct that from Whitehall. I think that's really the difference.
Mr. Whitty, I think that's a really helpful answer.
It is. So just one final point, if that's all right, Chair. That is a really helpful answer. So what you're basically saying is this shift towards the ICBs leading on this is welcome, and it's better that it's done at an ICB level rather than centrally. With that in mind, what work is going on to make sure that ICBs that do want to pursue this, where they have got very rural or a large coastal community that might benefit from this, are actually able to get on, procure and implement an NHS dental van in their area? Because I think that's, like you've said, there are those communities where it would make a big difference. How do we sort of enable and empower ICBs to get on with that?
Well, I mean, there is no barrier to ICBs doing this now, so they have the full powers to commission these services should they want to, and indeed, as we've talked about, some already have.
It's a bit worrying that none of them have. If we do accept that in some areas, it would help.
Yes, so I mean, some have, and we've talked about Devon, we've talked about Cornwall, there's different services, and I know we're short of time, Jason may want to talk about some of the other examples, but there's absolutely nothing stopping this, and we're supportive of ICBs that want to take it forward. All we're saying is we don't wish to impose it on an ICB where it doesn't want to make that choice.
That's really helpful. Both Professor Chris Whitty and you, Mr. Sparke, really helpful. Thank you, Lloyd Hatton. Clive Betts, please.
Right. So the development of the dental recovery plan, the formulation of it, engaged with stakeholders, except the feedback is they weren't engaged with very well. They didn't feel it was very satisfactory. There wasn't enough information there at the beginning. Indeed, it was completely obscure whether there was going to be any funding available, which made a pretty big difference to what you were consulting on, didn't it?
Yes. So I think the core concern that you've heard and you've read in the report is that the ICBs and parts of the sector weren't fully aware of exactly what was going to be included in the plan until at the very late stages, and indeed the plan had almost been ready for publication. And I think that is true. We were in discussions all the way to the publication of the plan about exactly what it could afford and what it would be able to deliver. That said, there was a huge amount of work with ICBs and indeed with other representatives of the sector about the kinds of ideas that could be included in the plan. The new patient premium, dental vans, you've heard already, golden hellos, all draw on and take inspiration from really good initiatives that ICBs have already been put in place. And we absolutely talked to ICBs in the course of those discussions about which elements of those could work and how we could take those forward. And we talked about the ideas that we thought would make it into the plan. What we couldn't do is tell them until the plan had actually been published exactly what was going to be included and under what funding.
Not a great place to start then.
Well, I think we were discussing with the stakeholders the concepts that are in the plan. So whilst it is true that the detailed plan wasn't shared in advance, we had talked about all of the elements. The new patient premium was based on conversations with the dental stakeholders, saying that they simply weren't properly paid for new patients, that there was a distinct under-reward in the concept. That's why we tried to do that. NHS England had lots of these conversations. We worked also at the Department of Health.
Okay,
the Minister had a round table in December to talk about these ideas. So there was consultation on what we were trying to do, if not specifically on the plan itself. We'd accept, we may do more of that.
If you're going to have a plan, you want to consult properly in detail with those who are going to have to implement it. Otherwise, it's not likely to work, which is probably one of the problems.
We had talked about the ideas in the plan, so I think it's not that we did something with no consultation.
That says a lot. I mean, people who are going to have to implement it on the ground, whether it be ICBs or dental practices, really need to know the details, don't they, to comment properly about whether they think it will work.
So I mean, if I may, so we had absolutely had conversations with ICBs about this is our idea, the new patient premium. What do you think? Same with the profession. And so there was an open conversation about them. What we couldn't do is say they're definitely going to be in the plan until we finalise. That's the only distinction we're making. So I think we knew that these, and we've seen in fact from the feedback since, that the initiatives themselves have been welcome. They clearly haven't gone far enough, and they clearly haven't always worked.
Well, let's try and just ask what you were actually consulting about, because it seems fairly fundamental. You're consulting about these extra 150,000. But you were also consulting about that anyone who wanted to see a dentist could do so. Which was it?
So I think the plan is clear that it sets out three aims that it's trying to, three stages. First, a set of initiatives for 24-25 that were aimed to try and deliver the 1.5 million extra appointments, which we've already talked about and we have not delivered. There's a section around really trying to improve the oral health of children, which would have a long-term benefit, and then a set of longer-term commitments there, which were really around further reform of the dental contract, so the things we've talked about today and we all accept need doing to come follow. A set of things to try and really get more out of the existing contract, including having ICBs use their new powers to reduce the contract levels of dentists that are not doing NHS work to allow them to give to others, which is only newly available to us, so that was part of this process. And then a set of things around workforce, both increasing the numbers of the workforce, as the Chief Executive of the NHS has talked about today, and trying to help with skill mix. So we have, for example, changed some of the regulations around practice to allow dental therapists and hygienists to do more things. So really freeing up. So there's a broader set of things that were meant to get
to the key objective, 1.5 million additional dentistry treatments, which hasn't been hit. Okay,
Yes.
that was a clear target.
Yes.
But then you had another target, whether it was an aspiration or a hope, that everyone who needs to see a dentist will be able to do so.
I think that aspiration requires to deliver all three of those elements I've just talked about, including the longer-term reform of the contract. And
Was that not
Can I just correct that last statement, just to be clear? Even had all of the aspirations of this plan been achieved, we would not have got to a point where everyone could see a dentist. So I just want to be really clear.
that was part of the plan, though, wasn't it?
It wasn't an aspiration, it was part of the plan.
It was part of the plan.
No, I'm giving you a mathematical statement.
Yeah, I know.
Yeah.
So essentially what we had was a grandiose aspiration, which was part of the plan, and a mathematical statement, and the two didn't link up, did they? They weren't the same.
Well, I wasn't involved in this at this
No,
stage, so
okay.
I'm going to stick to the maths. And the maths of this is actually, if you put the two together.
You're the
yeah.
interim permanent secretary, nevertheless, Sir Chris. So in your current role, you can see you have a plan.
No, I'm agreeing with you, Mr. Metz.
You
That's
agree?
not, that, no, I'm agreeing with you about your point. All I'm just saying is
Fair enough.
I'm not
Okay.
trying to explain the difference.
Thank you.
Yeah.
Done for the time being?
That's what I mean. Yes.
Yes. In sort of established practice of this committee, I'm now going to suspend this session to briefly allow for a short break. So we'll take a short break, and the clock is now at 11:27. Shall we say we'll be back here by 11:35, absolute latest, because we've still got a lot to get through. So, order. We'll now restart the session. Are we broadcasting?
You should be. It'll be coming on.
We are. So, welcome back to the committee's hearing on fixing NHS dentistry. Well, that's a very apt title, fixing NHS dentistry. If we could fix it all, we'd all be in a much better position. So, to help us again with that, I come to my excellent deputy, Clive Betts.
Thanks, Chair. We explored before what probably went wrong or what aspirations couldn't actually ever have been hit with the dental recovery plan. So just let's try and think what lessons we can learn going forward. What do you think currently are the most significant barriers which are preventing people securing access to NHS dentistry in this country? And were anything achieved through the dental recovery plan to address those barriers, or have you simply shown that the barriers exist and still need addressing?
Okay, I think that pretty clearly what they demonstrate is that tinkering around the edges of the barriers is worth trying things, but actually the problems are quite fundamental here. I actually think, although to take the new patient premium, for example, I think there was a genuine belief, not just in government, but actually outside it, that this would be likely to lead to an increase in people taking on new new patients. It was done in consultation with the BDA, which was mentioned, and others. And so the fact that it had no effect at all, now accepting that we don't know the counterfactuals, we don't know what would have happened if that hadn't been in place. Nevertheless, let's just take the numbers straight as they are. I think what this shows is this is a more fundamental problem even than originally you would have assumed. And I think that to go back to in a sense the whole tenor of what people were saying earlier, the gap between what people can earn through the private sector doing the same work and through the NHS is quite a fundamental one. It's not a tiny little gap we can just, with a very small amount of bridging, manage. And this is the whole point, in a sense, about the minimum UDA amount, that whilst a perfectly sensible move in itself, the idea that was going to bridge the gap and therefore solve any major problem, I think this makes pretty clear that is not going to be the case.
Is the fundamental problem then the nature of the contract, which we'll come on to with questions later on about the details of what might be done to change it? Is that the fundamental
my view, I'm going to give a personal view rather than this is the departmental view, is that in a sense you could fiddle around with the contract as a contract. The real problem is the gap between what is available for a good dentist in the private sector and what is available for a good dentist in the NHS. I think that is really fundamental. The rest flow from that. There's a lot you can do in terms of the details of the actual contracting, but that is the biggest, in my view, barrier.
Jason Wong wants to come.
Yeah, I think I agree that is one significant issue. I think the other issue to remember is the workforce and where the workforce wants to work and how they want to work. Maldistribution of dental workforce is a worldwide issue. Some of the cases raised happen more in certain areas. So we've got some areas where the activity has gone back to pre-pandemic levels, for example, London, and then others where members have already highlighted that disparity. And then it comes back to that fundamental question, which is, well, is it the fact that we've got enough dentists and that they just don't want to work in the service, or is it the fact that we haven't got enough dentists overall, or indeed dental team numbers? And for that, whilst the number of dentists is working, you have to look at the whole time equivalent, what they're committing towards actually clinical work. The General Dental Council survey suggested that 42% of dentists were working less than 30 hours clinically. So that's a cultural change. That's something that's happened, and we need to keep that in mind. Rurality, I think, is an absolute key issue. Not just because there's a general trend towards a sort of urban life and where the young professional wants to work, but actually there's some fundamentals in terms of where our specialist services are. So if you're a young dentist, do you want to go into an area? It's all right to have Charles Clifford Dental Hospital and a dental school there to refer to, for example. It's all right to have that where you can think about developing your career. But if you move into a more rural locality, you actually run into an area where you're thinking, well, how do I as a professional develop. So I think that we need to look at that. Where we recruit from as well, I think, Chris wants to come in, but where we recruit from as well, I think it's quite key. You know, the high grades entry into dental schools, and actually the available evidence is not necessarily where they train, is actually they quite often want to be near friends and family, and we're predominantly recruiting because we're not looking into widening participation from areas, and they tend to cluster around where they're from, but also where they've come from. And therefore, I think if you want services out in those areas, we need to look towards that long-term growth of that. So the pipeline that Amanda's just talked about, which is in terms of the NHS long-term workforce plan, I think that, you know, increasing our own production is key. And the plan did have some parts of it was also looking at international recruitment. I think Chris wants to...
I just wanted to add to that.
Chris, I'm going to bring you in, but given that really helpful, comprehensive reply from Jason Wong, and given, I mean, this applies across medicine, really. You can't deliver medicine without people. If the taxpayer is paying to train expensive professionals, shouldn't the taxpayer therefore expect that those young people, when they've trained, should actually spend a bit of time with the health service before they move into a more lucrative private sector?
So I'll add the comment on and then answer directly to your question. I mean, the first thing is, on the first point about the funding model, I think that is quite specific to dentistry. On attracting people to NHS posts in coastal, rural, remote areas, that is across the whole of the board. One of the previous questioners was asking about Minehead, for example. There were the same issues when I was last in Minehead. The thing I was discussing was how do we attract GPs to come to Minehead. Yeah. So this is not exactly. So this is not. We shouldn't see dentistry as, it's probably the most extreme, but it is not the only issue. And in fact, all around the coastal strip, I did a whole report on this. So for people who are interested in this, there has been a serious problem about attracting people, doctors, nurses, dentists, and other health and social care workers. So I think
have a meeting with you about Minehead then, please.
I'm extraordinarily keen to talk about how we improve areas of low productivity. So the answer is yes.
Brilliant.
But what I'm not going to be able to do is solve your dental problems immediately. Just to be clear, not to build up expectations. In terms of the so that's the general point. On your specific thing of should we require people to do this, there is a consultation on this, and Jason and others may wish to comment on that, because that was part of actually some of the way people were addressing this for dentistry specifically.
There was a commitment in the plan to consult. The consultation since closed, and we're sort of feeding up to ministers currently and working through that in terms of the consultation and the tie-in and what might be done for the dental graduate.
The consultation was launched the day after the election was called. So we completed that consultation asking, in principle, should we introduce a requirement for new dental graduates to spend some time working in the NHS. We've had that consultation response back. That's now with our ministers considering how to take it forward.
And so that's really helpful. And in that consultation, did you sort of discuss how long they might spend working for the NHS?
I think our time period was 3 years, but I would need to check for you. But it was a broad sense of, is this in principle? I think the practicality is exactly how it would come if the government wanted to do this.
Just come back to the feedback from the development plan, what you've learned from it. I know we talked earlier about Sheffield having this wonderful utopia where everyone can see a dentist when they want. That's not quite the case. And there are differences within Sheffield, as there are. I mean, we often say it's one city and two countries. The disparities in dental care shows that in terms of the more deprived parts of the eastern side of the city where I represent. Just one example there of something that isn't working under the plan, and how as a barrier, how you might look to address it. I've got Darnell Dental Practice in my constituency, Mr. Oliakis, who's the owner, the head of the practice, has got 12,000 patients. He's got, I think, general funding for about half those, and additional funding given for the other half, which expires in March. Now, he's taken dentists on, he's put new surgeries in, he's actually offered to take more on. He's got another surgery empty, which he can't use. And yeah, everyone knows there's going to be underspends at the end of the year, but they can't be anticipated. And what do you do next year with the underspends that are actually being spent this year, and dentists are being paid on that basis? Just to say, when I went to see the practice, there's 30 people in the queue down the road waiting to join. So you've got a really successful practice, more people taking on, but the financial basis is completely unsound.
So I think this is a really critical point, and I think you make a really important contribution. So we've got a couple of different things that are going on here. So the first thing to say is that even in your constituency, where there's relatively good access, even if all of the dental funds were spent, there wouldn't be 100% access for your population. We know that isn't, even in a place like Sheffield, there will be some funding, it's true everywhere, that is returned to the NHS every year because practices aren't able to deliver that care. And that's a really important feature and it's partly drawn from the fact that we have a contract that isn't attractive enough. It's also to do with some of the workforce issues that Jason and others have described. We've taken a number of steps to help ICBs to better prioritise the money they have available. So there's a couple of different things here, and I think it's relevant to your points. The first is we've given ICBs new powers to reapportion funding that isn't used from a contractor that is consistently under-delivering, so it can be reinvested in new contracts. It's really important. This is the first year where ICBs are able to take those steps, and we're seeing some really positive progress towards that from a number of different ICBs across the country. The second thing is we know there are contractors who reach 100% of their contract and want to go further. And we've been encouraging, we published some guidance on this a couple of years ago after the first set of reforms. And in the last 2 years, we've seen really positive progress from ICBs in making use of those additional flexibilities. So we know in year so far, we've got over 1,500 dental contractors across the country who have been offered additional activity by their ICBs because they're close to reaching 100% of their contractual value. So these are really important to make sure we spend as much of the budget as we possibly can.
What happens next year when the money, it's not repeated automatically into the contract?
So we might have to come back on the specific arrangements of the ICB that's put in place locally, yeah. but absolutely they all want to be prioritising sustaining that capacity into next year.
This empty surgeries, when we know there's going to be underspends.
Yeah. Yes. So the point that Ali's making about being able to take that contract back is really important. So those powers were only taken a couple of years ago. So previously, a dentist under-delivering, say delivering only 60% of their contract, gets awarded 100% of the value the next year, the next year, the next year. So we have now taken powers to allow us to draw that back. That will allow ICBs to think much more long-term about how they spend their money, because they will be able to essentially reallocate on a more permanent basis.
Yeah, and I'm not being critical of the ICB in South Yorkshire here at all.
Yeah, no.
Gavin Bowes replied to all my questions. He's going to come and visit this practice with me again to look at it, because I think we can see the future there. Mm-hmm. But yeah, it's not the fault of the local ICB, it's the fault of the financial framework.
Yes. And until 2 years ago, there was no powers for the ICB at all. So we've changed that. So actually we've given them the powers that might allow them to take decisions that they need.
Right.
May I just add one thing, which is just to say, I think, firstly, let's come back on the specifics, but on the general point, the important thing that we can do only from this year is permanently rebase contracts. Yes. So ICBs have been able to use underfunding on a non-recurrent basis, but now, because there had to be a number of years of underperformance before you could permanently rebase the contract, we've now hit that point. So some of your, I don't know whether that's true in this particular circumstance, but it may be that is part of the solution.
Is there anything else from feedback from the problems with the recovery plan, all the things that didn't work that you need now to address, that you can address?
So if I may, I think this does come back to the broader points we touched on at the start. So I think we've talked about the overall availability of money and the ability for us to repurpose that. I think that's the first key issue. The second is workforce, but the third then, and I think in many ways all roads lead back here, is the contract isn't helping us to prioritise the money we have properly for the patients who most need it. And that's why the changes to the contract that we've discussed already are really important.
On to the details of the
change.
Yeah,
sure.
Yeah.
Okay, right. Lloyd Hatton, please.
I suppose one of the things we've touched on in quite a lot of detail so far has been how those initial contract changes that were made in 2022, and also the recovery plan that we've sort of dissected in quite a lot of detail, what success they have had. And I think we've all agreed that in many ways they have fallen short of what we would want. So how are we learning from the shortcomings so far as we look towards what comes next, particularly after the end of March? And how are those lessons learned going to influence future reforms?
Well, shall I make a start?
Yes,
so,
please. Thank you.
If that's all right. So I think, I think we've talked in general in response to Mr. Betts about the kind of the broader messages we've taken from this experience. But I think, can I give you one concrete example? So I think the new patient premium, so clearly the way that worked was additional cash, additional money paid to practices on top of the value they would earn for a new patient anyway, irrespective if it was a band 1 or a band 2 or a band 3 course of treatment. We hope that would make a difference to practices' willingness to take on some of the patients who they know will often present with a more complex set of conditions. I think it shows the drawback of that as an ongoing fundamental reform to the system is that, of course, we know that some patients don't present with anything like that complexity. And so we were able to demonstrate that the extra time taken and therefore the amount that we've currently set for the new patient premium was justifiable based on the evidence we had about the amount of time. It goes back to the question about the modelling and the cost earlier on. But if we did make that a wholesale change to the contract, we know that we'd be fundamentally overpaying for certain patients who are coming through. So that's why changing the underlying payment mechanisms, and this is the learning, I think, is really important, because it means that we can better tailor the resources we're giving to practices to the actual needs of patients. And that's when Sir Professor Chris referred earlier to the initial changes in 2022 to create different sub-bands within Band 2. It's that sort of change which is important, and we want to go a lot further than that.
Do you think, having learnt the lessons of what went wrong and also what worked before, we can address the issues that Professor Whitty was highlighting around making sure that while the number of overall dentists has gone up, the number of those providing NHS care has gone down? Do you think actually that what you're talking about now will mean that we can address that quite sort of fundamental structural problem that we have fewer dentists actually working with NHS patients?
So yes, I think it will go some way towards addressing that issue. Clearly what it won't address is that even if all of our money was spent, even in the most appropriate way, we would still have close to 50% of the population who wouldn't be able to access dentistry. So I think it would really help us in prioritising, which is, I think, our fundamental job, to make sure the patients who absolutely need this care receive it. What it won't do is create universal access for NHS dentistry.
Okay, and then just one final point, as we look to sort of learn from what's happened so far in the last few years and what comes next, particularly around the Golden Hello scheme, I'd be keen to know about what work has been done at a grassroots level to actually talk to those providing dental care to make sure that actually the scheme does deliver what we aspire to deliver, which I think is the right aim.
Yes.
But we've appreciated it's been a bit slower than we'd hoped. What work has been going on to work with those sort of from the bottom up to make sure that it is more of a success in the future?
Yeah, so we've started a programme of evaluation now. We always intended that to continue into the new year once we thought a number of posts would be in place. So we'll be able to come back and give a more detailed answer on that, I think, in the future. But what we can say is that we know that the scheme itself was designed with a number of very specific purposes to target places which had an ongoing long-term recruitment problem, in places where we knew there was already under-delivery and access issues for a particularly vulnerable or difficult to reach population. And those broad lessons were drawn from existing experiences of other Golden Hello schemes that ICBs have already done in different parts of the country. What we're referring to here is a national version of something that exists in different places in different ICBs, and we know they have found successful. So we have reason to believe it's right. We don't know whether for some of the most difficult places where there's really challenged workforce availability, whether this will be enough to actually encourage dentists to relocate for a longer period of time, for the 3 years that we've hoped. But that's one of the things we'll learn as part of this evaluation over the next couple of months.
One quick...
So hang on a minute. You say you don't know whether it'll be enough. Surely you could go out and ask them.
Well, as I say, we've used that. We based the value that this is £20,000 available to dentists under this national scheme, split over 3 years. 10,000 the first year, then a further 5,000 the subsequent 2 years. That is based on experiences that we have seen in different parts of the country where golden hellos have worked. And it's also based on the similar GP scheme that has been in place for the last number of years as well. What I'm not saying is that we can guarantee that in every part of the country that is struggling to get a dentist, this will be sufficient to attract. This is because we do need to fix the contracts and some of the other underlying causes of the NHS not being a sufficiently attractive system at the same time.
Thank you. Lloyd Hatton.
Just one final point, if I may, Chair, is just in terms of it'd just be really useful for the committee to get a better understanding of when you are doing this sort of bottom-up engagement with dentists and with the wider workforce, what are the main challenges that they are actually coming back to you with? Because I think what would be sort of really useful for us is to get a better understanding about actually, even with these schemes, things are obviously deteriorating. As we have examined, most of the figures are going in the wrong direction, and the number of dentists providing NHS care has been going down. So what is actually the feedback? It sounds that there has been some genuine engagement, which is welcome, but what are you hearing? And are we going to make sure that whatever comes after the end of next month, as we look beyond the current recovery plan, actually takes that into account?
Yes, and I know Joseph wants to come in, but let me just say, I think everything we've described so far comes out of a range of the conversations we've had with different, and not just dentists, but also therapists and hygienists and nurses. We've run a series of focus groups over the last 18 months to try and understand and get underneath these issues in a much more detailed way. And I can come back to some of the detail of that if that's useful, but I know that Dr. Wong wants to come in.
I think one of the sort of feedback we've gotten is whether the incentives were strong enough for people to change behaviour and accept new patients. And one of the worries I think practices, providers and performers have is opening the book to what they see as the risk of someone with the higher needs in terms of the level of treatment, the complexity of treatment that is. So I suppose the lesson to be learned from this onto the next is that if you're going to have an access scheme of any sort, and be it originating from a urgent care basis or routine care, then you must do something to address in terms of the incentives that the practice has. So where there is a higher needs and higher treatment needs and higher treatment need to be carried out, that needs to be worked in as part of that plan. Because you pull the lever here, it won't affect the other. So the remuneration system must change on that part, so that if they do have the high needs patient coming in, that is something that has been looked at and rewarded appropriately.
And that is a significant structural change. As I said earlier in today's session, there is not a single dentist practice in my constituency which is taking on new adult NHS patients. So do you believe that the engagement and the consultation at that grassroots level has been sufficient, that we can begin to turn around that sort of structural problem where more and more of those dentists are actually going to, for the first time, reopening their books and saying we will take on more NHS patients? Because actually, even if we do a number of the reforms which you've outlined today, which I welcome and support, we do have to fundamentally change that structure where you can have whole swathes of the country where not a single dentist is willing to take on a new NHS patient.
I think what we can say is that idea of remunerating that part appropriately is not only part of longer term reforms, it's actually part of the thinking in the next set. So yes, is the short answer in terms of that that feedback is going to feed into what we brought in order to make that change.
And I suppose the last question, which is the million-dollar question, is how quickly do you think we could expect to see those sorts of changes? So communities like mine, but I know for many others on the committee, will start to see a dentist practice begin to take on new NHS patients. Because I think that's what's really important for patients in my part of the world, is if they look online, they go on the Dental Choices website, and there is absolutely nobody taking on a new patient. They would like to know what is the time frame for when that might begin to change.
Not sure I can put an exact answer onto that, but the hope would be that some reforms is fairly imminent, and obviously will await such announcements. So and there will be variability. I think that's probably something that we need to address, but some of the initiatives, it depends whether you sit on the incentive part. I actually think both is going on. I don't think you can ignore the workforce part and what drives that as well as the system. But there are some in terms of addressing certain parts of the population where you may be able to flexibly commission, and that might be much quicker than other parts, the more structural parts.
So can I just add to that? So I think that on the two sets of onward work that we've already described, so on the urgent care work, we already in discussions with government, as Amanda said earlier on, I think we can see progress on that very quickly, and that won't address all of the issues your constituents are facing, but clearly where there's an urgent need and where there's a need for a safety net and a meeting of their immediate requirements, particularly for people in pain, I think we can say that we expect to make very quick progress on that over the course of this year. It was in the planning guidance. Clearly, for some of the more fundamental changes in the reform, the discussions we're having with the new ministerial team are important. It's obviously a decision for them to make.
If I could just put one very brief final piece to you. I mean, a constituent came to one of my coffee mornings, and an issue they raised, which was particularly frustrating, is that when they went onto the NHS Find a Dentist website, it did list some dentists as taking on new NHS patients. But actually, when they then picked up the phone or sent an email, that wasn't the case. They weren't. That is deeply confusing and deeply frustrating. So as I've pointed out, there is not a single dentist taking on a new patient, and yet the NHS's own website gives a list of those that are. So as we look to implement future reforms, and as we go beyond the current recovery plan, and we do this extra engagement and consultation, which you've already been doing, how do we sort of address those big gaps where actually you have patients that are being told one thing by the NHS website, but a completely different thing when they pick up the phone to speak to the dentist?
Yes, I mean, I think you raise a really important point. It's clearly incredibly frustrating for patients, and we hear that as well. We should stress that the website itself is updated by dental practices, so they're the ones that are posting that information. So what I think happens sometimes is that information becomes out of date, or they do see some new patients, then suddenly that it's no longer relevant. So we already introduced in 2022 a requirement to update those profiles much more regularly. Clearly, there's a long way to go, as you've just highlighted. But some of this will come down to fixing the fundamental issues that are preventing those new patients from being seen in the first place, and therefore the website itself will never be the whole answer. But I completely accept that's very frustrating.
You can see where my constituent is coming from when they have this bizarre situation.
Yes.
And then actually you're saying, well, in the future we will get to a point where we are starting to see some dentists take on new NHS patients. They need to know who those dentists are, and they need to have a reliable place to find that information. And right now, if they go on the Find a Dentist website, that's not the case.
45% of practices at the moment, as of the latest report we have, are advertising to us and to patients they are taking on new patients in their practices. Clearly, as you've just highlighted, that is not always the case in practice, and we do need to understand what the reasons are for that misalignment of information. I agree.
Thank you.
Can I come in on the back of Lloyd Hatton's excellent questions? And NHS Gloucestershire, they're innovative, but they do say that they're currently only achieving 68% of their contracted targets they've been set. And no doubt they will, at the end of the year, have money unspent. And the NHS, Professor Chris, has been playing on this business that there's 200 million unspent. But that's not really the answer, is it? If people like Gloucestershire don't have the levers available to them to be able to address the problem. So the two questions from me, really. One is, do you think this new contract is going to give them the levers they need to start really seriously addressing the problem? And is the NHS going to put some real new extra resources into trying to solve this whole problem so that we maybe begin to actually solve this gap between the private sector and the NHS?
Okay, well, I'll give a departmental kind of view, but I suspect Amanda will want to give one from the NHS. I mean, I think that there are several issues, but I'm going to highlight three in particular, some of which I think can be solved and some of which I think are going to require a more fundamental rethink, which ultimately is one for ministers to decide where they want to put it. The first one is a bizarre situation that was previously talked about by some of my colleagues, where one dental practice can have reached the 100% of their contract, wish to go further, have patients who want to be paid, and they're not allowed to, whilst down the road there's another dental practice which actually has not done their full allocation. And the obvious thing to do is to switch the money from the one to the other, but that is currently difficult. That, I think, is a solvable problem and should be solved with some of the changes that are being made at the moment. And that's a mechanistic one, but that is a daft situation, and I think everybody would accept that is daft, and that daftness needs to change. The second one, which is more fundamental to that, is that, and this is the one where we read, there will need to be quite a big political decision, I mean that in broadest sense, is the total amount of funding which goes to dentistry, and specifically how much money per unit of activity. Because part of the reason, the second reason that people actually underspend their dental contract is that they're offered money at an NHS rate and they choose not to take it because they're using their time to do private practice, perfectly legitimately. This is not a criticism of the dentists, that is simply a statement of fact. And that is because they don't see, at this point in of time, the NHS rate to be appropriate compared to what they would be able to achieve in other areas. So that is quite a big issue that needs to be dealt with. And then the third one is to have a ring fence around the dental budget so that there isn't, in a sense, almost an incentive, although I'm sure it wouldn't be seen that way, for ICBs and others at the end of the year, knowing that this money is available, to shift it into other areas of the NHS which are under pressure, which are always pressures, as everybody knows, for their own areas. And having a ring fence around that at least means that people will be very serious that this money must be for dentistry. Now, there can then be a very legitimate political discussion about what is the correct ratio between dentistry and other areas of the NHS. I consider that's a political question. But at least the money that has been allocated by ministers to dentistry should be spent on dentistry in a way that actually deals with some of the appalling problems that some of the people around the committee have been rightly highlighting.
Part of my question was, and that's great to hear it's going to be ring fence, because that does give people an incentive to really think about it and really think how they can spend their money most effectively. Do you think the changes that we've been talking about this morning will be sufficient levers to enable them to spend that money? Because the problem is they can't spend it at the moment.
At the moment, well, I'm leaving aside the ones I've just talked about, and as I say, Amanda want to come in. I think the changes will be sufficient to make some useful movement, but for fundamental reform, and that was the word that the Minister used earlier this week, so I feel comfortable in using it in a sense, then that is what we will need, I think, to significantly shift the dial. I don't think any of us think that relatively modest, these are important changes, but these are not sufficient to deal with the gap between where I think the public rightly wish the system to be and where the system is at this point in time.
So, I mean, I'm going to press you again because we did cover this earlier on, but what I would like to try and get out of this session is some sort of confidence from you that we're not going to be sitting here in 5 years' time in the same sort of situation. We will really have delivered a much better dental service to our constituents than we are now.
Well, I think that the right time to ask that question, and I'm not being weaselly about this, I'm being realistic, is when the actual plan has been laid out. Ministers are looking quite across the whole board of the NHS, including dental practice, in a sort of bottom-up way. They've been very clear about this, the 10-year plan. I think at the point that happens, I think it is legitimate to ask people, well, do you think this is going to do the job? But I think at the moment, since we don't know that, and part of the reason I'm being cautious, if I'm very honest, is since the beginning of the 1990s, a whole series of changes have happened, each one of which people said this is going to fix it, and each time things have got worse. So I'm very nervous about kind of sitting here and saying confidently the next plan, which I don't yet know because ministers haven't yet agreed it, is going confidently to fix this because previous plans have failed to do so. And I think we do need to bear that fundamental reality in mind when we're discussing this.
Okay. Rachel, go on. Sorry, did you want to come in, Amanda, please?
If I may, Chair, just because I couldn't agree more with what Professor Whitty has said about reform, but just to reassure the committee, one of your key questions, I think, was, are we going to spend the money that has been allocated to dentistry? And will the things that we've talked about as the short-term, which are not attempting to fix the bigger picture problems that we've discussed today, are they going to get us further from where we are now, so we are not returning money back unspent when there is such an obvious level of need that is not being met in dentistry. And I think I can give some confidence that certainly the sort of 3 things that we're doing right now will make a difference. So actually contracting for urgent care, additional activity in a different way as extra activity, working with commissioners so that they are developing enhanced access schemes locally, and this ability now to rebase contracts where there has been historic and persistent under-delivery. Those 3 levers are important, and certainly this coming year we would expect, as in 25-26, people to have much greater degree of ability to spend the money they have been allocated on dentistry. My caveat on that, and we've talked about it a lot today, but is workforce, because it is not as if we have a lot of dentists who are sitting around not working. They are working, they're working very hard, and if they're not doing NHS dentistry, they're doing private dentistry. So in order to fix the workforce long-term challenge, I do think this incredibly important point about training enough of our own dentists and then keeping them within the NHS just can't be ignored.
I suppose the lie is that are you to put the money where your aspiration is? Are you reasonably confident that if we have you back to examine the 25-26 situation, that all the money allocated to dentistry will have been spent?
That is absolutely our aspiration. As I say, where I would be concerned is just where we know we have not got enough dentists. So that is my one caveat. But I should add a technical point, but I think important, is we are, in agreement with ministers, going to make sure that dental delivery is part of our formal oversight framework for the NHS for next year. So we will be actively monitoring and holding to account ICBs, some of whom are doing an amazing job, but we will be holding them to account for spending this budget.
Really helpful. Rachel Gilman, sorry.
It's okay. You mentioned the workforce, which is what I'd like to question you about. So I'm presuming that you've got new data on the dental workforce, which informs the decisions that you make or the initiatives you make. But how are any future initiatives on workforce support and development? What sort of support and development have you got in mind, or data that supports it?
I mean, we're very much supporting the use of skill mix, so using the wider dental team in which to provide care. And both in 22 and 23 and continuing since then, resources have been sent out to help the profession and to help providers in utilising that team. And the other part, as I said, is we need to start to think about how a career structure in terms of for the dentists coming in certain localities that don't have the support in terms of their development that they have that opportunity. But as Amanda said, we do have sort of dentists in full employment. I'm still convinced that there is a number issue here, and that we do need to grow that workforce in terms of numbers as well. So in terms of how we're trying to support it, part of the reform plans and the commitment is to how to make the workforce feel more part of the NHS, because I don't think that's where the workforce feels it is currently. So it is a case of making sure that they are feeling safe in providing that treatment. Aside from the NHS and contractual issues, there is a feeling at the moment, I think, within the workforce that that the current either clinical negligence or regulation system is kind of slightly stacked against them. So there's a real culture within the dental workforce in terms of how it feels in terms of providing care. And I think we need to address some of that. Some of that is about seeing whether legislation could be updated so that those processes can be much better, and that there were discussions that we've had in terms of both the clinical negligence and the regulation system with the General Dental Council. But I think it's really, really important not to lose sight, apart from the incentives, which is really important, that actually it is about making sure that they can provide safe care and feel safe in doing so. So in some respect, everything that we talk about seems really complex, but actually at the basic level, that is the reason, that's the place we need to get to make sure the workforce then provides the care that we want them to provide.
When I use the term workforce, I'm not just talking about dentists.
Yeah.
I'm talking about, the ability to start as a dental nurse maybe and have the confidence and the ability to grow in your professional role so that...
Indeed.
I mean, I have a situation in Dulverton, or I had a situation in Dulverton in my constituency where the only person that provided the NHS care was a trainee. And I don't think that's fair. I don't think it's fair on my constituents, and I don't think it's fair on that trainee.
We are doing some work in the dental nursing group. Is the biggest registered group within dentistry, and we're doing some work in conjunction with the chief nursing officer in terms of how we can make the whole professional group develop, so that you don't have to leave the profession in order to do it. At the moment, they have to go into dental hygiene, dental therapy, or into management. A lot of the reforms were aimed at dental therapists and dental hygienists as well, and I think that's quite important. Another group we're trying to help as well is the clinical dental technician, actually the smallest registered group who provide removable prosthesis. We've put into plans to give them a preceptorship or a foundation year so that they form part of the workforce there as well, and they can have direct access. And the NHS took the steps that the direct access is able to be provided by the clinical dental technician, dental therapist and dental hygienist. And that's really important. Yes, it took a while from when the legislation allowed it, but now that they can work via direct access. And we've seen some encouraging data in terms of the amount of direct access that's coming out of those groups.
So you're talking about retention, aren't you?
Yeah, we're talking about retention and how they feel that they can be part of the NHS and how they can develop.
Thank you, Rachel Gilmore. Peter Fortune, please.
Thank you. Actually, I'll pick up on that because a couple of people have touched on this. We're essentially talking about the liberalisation of dentistry to a certain extent here. So the option could be that if you're having a checkup or a filling or polishing, then actually somebody like a dental therapist could do that. And that's not a drop in quality, right? Because they still have 3 years worth of training, but it's probably half the cost. So there was a paper on this by Tim Lernig, I think, which talked about this. Is this something that's being looked at in terms of where that delivery could be? Because that would increase capacity as well. I think
we can come back on that. It's not. You're exactly right. Not talking about any drop in quality whatsoever. Yeah. And indeed, really, the cost is a side issue. Obviously, they take less time to train. That is correct. But within the surgery setting, we also think that actually it allows the dentist to develop and work to the top of their scope as well. So we want all the registrant groups, including dentists, to be able to work to the top of their scope. So it's about the team working as a multidisciplinary team. We're not being particularly good at as a profession, as a sector actually on this. Other professions, if you walk into other places that have that split, we still seem to believe that the only work that carries out is with the dentist sitting right next to the patient. And it's something that I think our profession will need to progress on.
I think it's interesting because I think the cultural element of this is going to be really challenging. I see Ali wants to come in as well. But I think a couple of people have hinted and touched on this because people want to go and see a dentist, and that's what we need to look at.
Yeah, so I think it's a really important point. And can I just add two brief things to what Jason was saying? So the first is that in 2022, when we last announced the package of changes, one of the things we made quite a big deal about at that point was how there's a sort of widespread misapprehension that other members of the dental team can't actually deliver a course of treatment, particularly a Band 1, or carry out some of these activities on the NHS. And we've published some guidance on exactly that, and we have seen over the last 3 years the number of courses of treatment that are being carried out by therapists increasing. It's still at a relatively low level, but it's increased from almost nothing to sort of 4 or 5% of course of treatment now. It links back to the reform question though, because the way we pay for and structure the contract incentivises the course of treatment to be delivered by dentists because it's quite hard to separate out some of the other activities and do them separately. One of the things we'd like to address, and we're talking to government about this at the moment, is we are seeing too low rates of evidence-based prevention activities in children. For example, fluoride varnish or fissure sealants. We know those don't need a dentist to be delivered, but the current payment structure doesn't really support them being able to operate independently on the NHS. So one of the things we'd like to do is to be able to better support for example, extended duties dental nurses, to take back to the last question, to be able to do some of that work themselves within the structure of the NHS contract, but really trying to develop the whole team. So I think it's really important to go further on this.
I sense, and I know we're short for time, but so I do sense some hesitancy there because there is that cultural shift with the public.
Yeah.
What about the profession? How would the profession feel about that sort of change of delivery?
Well, I mean, I think the public, whilst there's definitely a core that want to see that specific person, actually the public, as long as you're delivering good care, probably don't have as much.
We've
of a
changed, didn't we, recently in terms of seeing pharmacists and
GP. But in dentistry, not to do with the remuneration system. It's just that the cultural shift for the public is their relationship with the practice, with the essence of that, rather than with the set individual, and that's been changing a little bit already. In terms of the profession, I think it has been welcomed in all quarters. I mean, the introduction of skill mix and moving on. There are certain parts, I think, that we need to make sure that there is parity within the system for all people that work in it. The NHS's relationship is with performers and people with performer numbers, and part of the aim is we need to make sure that the NHS's relationship is with more than that and making that whole team feel part of the NHS. So I think we have to move and shift that in order to shift the profession sort of feeling part of it.
Unions broadly supportive of that direction of thought?
Yeah, I've not had anyone approach me and think that the whole idea of skill mix is not something we should pursue, even from the union.
So, given that the workforce is such a vital part of this whole recovery plan, and we've received evidence, I'm going to put this on the record, and it's slightly long, but I want to get your reaction having put it on the record, because I think this is really, really important. So the Dental Schools Council have given us evidence, and they've suggested a few things. They say established outreach centres associated with the existing dental schools in underserved areas to expand access to care and increase opportunities for students, explore innovative approaches where students complete foundational training in local institution and later finish degrees in more specialised setting, the government-led recruitment drive for staff for dental schools corresponding to bigger numbers, including local clinical supervisors and dental nurses, the dental recovery plan, previous government's long-term NHS workforce plan proposed 40% increase in training places for dentists and dental therapists by 2031. Retain the 40% uplift in cap and dentistry places, but prioritise funding for new outreach centres, including flexible graduate programmes, etc., and widening participation, recruit students from disadvantaged areas to address workforce distribution issues, as was made the point, I think, earlier by you, Jason, as students are more likely to work where they grow up. I mean, these are sorts of issues that you're thinking out of the box and really considering how we can recruit and train more dentists.
Yes, I'm just trying to make sure I've got them all, but I don't think I disagree with the push of any of the issues raised there by Dental Schools Council. I think the widening participation. There's a real question, I think, when we're considering long term where we actually want the workforce to be. If we're sitting here in 2040, do we still want, and this is not just about the NHS, dentistry provided predominantly 95% by dentists, or do we want to change? And if you do want to change, if you don't want to change, then there is a real question whether the straight A students and where we're carrying out the training right now is actually the right process, or whether you should widen participation. I think it's fundamental to the future. I recognise the longer term future, and we've got some issues we need to address before that. But yes, I think, and having the treatment carried out in areas that are underprovided, very much in terms of outreach, very much is part of the plan. We supported the increase in numbers.
Very helpful. Anna Dixon, please.
Yes, so at the very early in the hearing, I think there was a general view, and I was pleased to hear it from yourself, Amanda, recognising that the dental contract, as it currently stands, needs radical reform. I think that was a broad view. So I'd just like to come down to sort of some of the potential options. We've received evidence from a number of different organisations. So one idea, Health Watch England, they suggest introducing a weighted capitation system, and they would like, I guess, to reverse the 2006 contract and ensure that everybody has sort of the ability to permanently register with a dental practice, much like we do with a GP. And certainly that sort of lifelong relationship that I enjoyed growing up with my dentist. In contrast, the Nuffield Trust say, well, let's accept reality. We have a partial service. We cannot go back to a universal service, and we need to focus the public sector, both dental capacity and I'm guessing they would mean with this public sector expenditure, on those who can't afford private care, people with elevated risks such as those with dementia, and children and others who benefit from prevention. And then the NHS Confederation, obviously various suggestions about much more flexibility as we've been discussing for ICBs, to look at local needs, to commission in line with that, and thinking there perhaps much more about assessing and paying for oral health outcomes, a much more population approach to rather than rewarding dentists for treatment and activity. So 3 quite contrasting options. What options are on the table as you consider this in terms of future reform?
Yeah, I mean, I think dividing things into the kinds of things which are actually really largely for technical people like Amanda, Jason and Ali to deal with, and things which are going to require quite a political choice. I'll leave them to deal with the more sort of specific ones. On the bigger kind of questions, all the suggestions you put are perfectly reasonable things for people to consider, and there's quite a long list beyond that. I think what ministers have got to do, and this is clearly a job for ministers, it's a political choice here, is choose which of the political philosophies in a sense they wish to follow between those different approaches, and then build a service around that fundamental choice. And they will be looking, I know they are looking at a whole range of different ideas, including all the kinds of things you've talked about. Where they will finally come down, I don't yet know, because they haven't yet come to a final conclusion on that. And it's, I can't prejudge where ministers will choose to land, but I mean, all these kind of things are perfectly reasonable for us to be debated. And actually, this is a good time for people who've got strong ideas about how the whole system can be fundamentally rethought, to put them on the table and say why it is they think that this is a better model.
So thank you for that answer, Sir Chris. I guess ministers are also wanting advice on value for money. So in setting out any options, the analysis that you already have around, which we've spent the last 2 hours discussing, on what has and hasn't worked, where value for money, not least that we do know that there are people perhaps who are at the wealthier end who still somehow have managed to retain an NHS dentist and accessing, and yet many of us have many constituents who literally cannot access dental care because they cannot afford to make the choice to go private. Yes, I understand there are political choices that ministers will, I'm sure, be considering. But in even appraising the options, how confident are you that you are able to assess the value for money of different choices about how to target the current modest spend, as we've been discussing, better?
Well, I was talking about the more fundamental changes. I think on the second, I'll turn to Amanda, but on the on the fundamental changes, the committee have rightly highlighted a number of things which are major priorities. There's a geographical disparity. There's a disparity by age. There's a disparity by severity. We haven't talked about this, but there's a disparity by ethnicity. Now, you have to actually look at all of those, and to some extent, you've got to start off with which is the one that drives it, accepting you're having to do all of these, and which will be the most cost-effective way to approach each of those will vary. These are analysable problems, as you absolutely, as given your previous roles, know completely. You have to start off with what are the choices that are in front of you, and then analyse those choices. And there isn't an abstract what is the best value, because it really starts with actually what are you fundamentally trying to achieve in the changes that need to be made. But I mean, that is exactly what we should be doing, is supporting ministers who say, I want to achieve these aims, and then say, okay, here are the best, most cost-effective ways of doing this, and here are the trade-offs. Because the budget, to make a point that was previously made, the current model cannot actually cover more than 50% of the population. Now, you could change the model completely, but that's the reality. So then the question is, within that, how do you actually prioritise the different very important points that people have made? That is a fundamentally political decision. There is an analytical underpinning for that, but that has to be for elected politicians to make that, in my view, make that judgment. But then there are the more day-to-day analytical things, and Amanda, you might want to talk about those.
Yeah, I mean, I suppose I'd be interested in sort of, what's on the long list, and are there things that you've done in the past that you just know don't work, so you're not even, they're on the sort of don't even put them to ministers list because there's just, we've tried and they've failed. So I suppose I'm just trying to get a sense. I appreciate that you can't prejudge a minister's decision, but I think we are keen in this committee to understand, that there are lessons, and that, value for money appraisals, evaluations have been conducted and are informing future choices on this, and also learning from other, we have consultants who have contracts that allow them to opt certain sessions, but you do then, tie them to doing a certain amount of their working hours for the NHS. That would potentially address the erosion of hours. So I suppose I'm just trying to get a bit more of a flavour without obviously preempting what ministers might be.
Well, I'm as someone who, dentistry was new to me when I started looking at this for this committee, and it's been a voyage of discovery and not a very encouraging one, I have to say. And one of the things that I've come at, what is really clear is there's quite a lot of things that have been tried and failed. So we can give ministers a long list of failures going back to the early 1990s, unfortunately. There are a few things which have been tried and were successful. I consider the 1922 changes, which split, I know the chair said this is too detailed, but I'm still going to say this, that split the Band 2 activities was a genuinely useful change. Unfortunately, and as we were discussing all the way through the first half of this, all the things that were tried in the dental recovery plan were perfectly logical, and indeed at the time they were being put forward, large numbers of very sensible people, including some of the people you talked about, said this is a sensible idea to do. The fact is that in particular the new patient premium did not work. So there are quite a few things we should really take off the table and simply say perfectly sensible, has been tried, has not worked. But I think we should be clear that there isn't a situation where we can say, actually, 5 years ago there was a brilliant system, and if only we'd reverted to that or whatever. The last time I think most people in the country would consider that NHS Dentistry was operating as they would anticipate it should do was probably in the early 1990s. And the changes since then have all tended to either do nothing or make things worse.
Well, that was the period when I was doing my masters and learning about dental public health. So, I remember reading papers then which said that there was a thing called supplier-induced demand, which said when you pay dentists by activity, you're going to get them to do things that they don't need to do, and basically it's the sort of stuffing their mouths with gold. Obviously, we've changed things in the GP contract, like quality and outcomes framework. We've got plenty of other evidence-based approaches to how we pay professionals to get better outcomes and do the things that we want to do. So I really would be hoping that in fundamentally looking at the dental reform, you will be looking at all of these things. But were you indicating that, yes, Amanda and your team, would you like to add anything more on the sort of dental reform? And I'll turn to...
very briefly, because I think Professor Whitty's covered, absolutely nailed the bigger picture issues. What I would say is, clearly policy making sits more with the department than it does with us, but the important thing will be, we talked about this earlier on, you've already mentioned it again, Mr. Beale's, making sure that we have got really good underpinning modelling, because where I think, so really good underpinning modelling, really learning from the past, what we've tried in this country, clearly looking at what we can learn from international examples, and then I think there are a set of political decisions that absolutely are important to overlay on that. Good policy making will require us not to do this at a rush, But clearly there is an urgency here, and nobody wants to see the current state of affairs continue any longer than it needs to. So I think that is why the way that we're trying to do this is do within the existing contract the things that we can just crack on and do now, make sure that we're doing the next set of probably more minor contractual reforms, but nonetheless things we can see are going to be in the range of things we talked about earlier. I won't go back over them, whilst this much more fundamental piece of work goes on to look at what a completely radically rethought approach to dentistry might be, in line with what Minister Kinnock has already said.
And if I could just add that we talked a lot in this committee about the development of the current contract. We did spend about 10 years from 2009 looking at, could we do a capitation contract? So you would have essentially a registered list, you'd be paid for those. Pilots for about 5 years, and then a prototype contract between 2016 and 2020. The evaluation of that found that access reduced, activity went down, there was no significant increase in preventative work, and we collected fewer patient charges. So we stopped that in 2020. That didn't seem successful. Now, not to say there isn't another way of doing capitation, but we have had some quite significant goes at trying to do a different contract that, as Chris has said, haven't proved to be hugely successful.
Thank you very much. Danny Beals.
Thank you, Chair. Just further building on the contract, you talked about it, the need not to rush, which I think it's true. We need to get this right. But what timescales are you working to on a new dental contract? Have discussions? Has the process started? And when do you envisage an end date to be for an updated dental contract?
We are talking to our ministers about significant reform and fundamental reform to the dental contract. I think there's three things that we should think of timescales. Ministers are very clear that the urgent thing they want us to address is access for people who have urgent needs. So it's in the planning guidance. We expect to see significant progress on 700,000 more appointments. So that will make an immediate difference now. And as we talked at the beginning of this process, we're doing that outside of the contract so we can make it happen and learn some lessons. So that's part one. I think we will be looking with NHS England on what are the sort of the changes to the current contract that can make a difference, and whether those are worth doing, and we have those conversations going on. Ali's been talking to the BMA and others, and then we are having a more fundamental conversation. BDA. And then we are having a conversation with ministers about their appetite for more fundamental reform, which needs to work through.
Thank you for that explanation. So it's fair to say, from what I've read between the lines, is the process of a new dental contract has not started yet.
We are working with ministers on proposals for both short-term changes and what they might want to do for a more fundamental reform. I think we need to do that carefully, and clearly ministers will come and talk about their decisions when they've taken them.
So, and I'm reading into that, maybe I'm over-reading it, but a significant process of a new contract hasn't started at pace yet. What would a timescale for a new contract be, do you envisage? I appreciate, we need to get it right, not rush, but what would you envisage? I think we've all accepted, it's come through that we need a new contract. That's what I've picked up from this inquiry, from what you said. So if we accept that and understand it would be complex, I'm keen to understand what the timescales would be for a new contract.
We'll have work to do to think about what level of change and what level of reform we want to a contract. So, a very significant reform contract will take longer. We are working through those options of what ministers might want now.
How long would that be? Would you envisage a significant new contract?
So I think, as I've said, I think we've got immediate work that we have already committed to get increased access to urgent dental care. We will look at what are the short-term changes that made the contract.
It's not really my question. It's the previous point you made. But perhaps you can write to the committee with what the options might be. But my question was, a new contract, what time? I appreciate you're tinkering the contract, you're doing other things.
Taken about what sort of contract we want. Those decisions have not been taken.
Yeah, so we have not started the process significantly.
I think,
Chris, we have started that work.
Hang on, Professor Chris, I think Danny Beals is asking a reasonable question, and I think I would like to back up his request that you write to committee with a timetable as to the short term and the long term. Because if I was sitting in the middle of the Cotswolds, not able to get a dentist appointment, I'd want to know when I'm going to get that dentist appointment, or am I going to be dead before I get the toothpaste seen to? So I think we do really need to have a timetable. We do not want to be sitting here at the end of this Parliament with no improvements at all. So could we have a fairly detailed note from you setting out a timetable?
I think I'm going to promise half of what you've asked for, Chair. I think doing a detailed timetable on all the things we can do within the current framework, I think we can provide largely for NHSE relatively quickly and with some precision. actually the rest of it does depend on political decisions over which, with the best will in the world, no one on this side of the table has any control. And the level of fundamental change will determine how long it takes to actually get these things through to happen. So I think the ministers have been very clear that they're going through their 10-year forward look and their 10-year plan, and I'm anticipating this being either part of that or very closely associated with that. It'll follow in broad terms, the timetable of that plan. But I think it would be very dangerous for us to start making promises in detail about sort of milestones from here, because they start with what are they intending to do, and that is really the starting point, and we haven't got to that final starting point.
Okay, I've got one other question, and I'm going to bring in Lloyd Hatton. You've got a consultation on fluoridation, you've got a consultation on the wider dental recovery plan, but I think if I was sitting watching these proceedings, I'd be getting more and more frustrated by saying that I use the system. This is one of my constituents in the Cotswolds. I know what needs to be done to fix it. So my request to you is, to get your reaction, is why don't you have, given that you say you need to, Miranda's been very clear she doesn't want to do this in haste, and I agree with that, but why don't you have a more wider consultation to allow our constituents to give their views? They're the people who are going to be using the system. Why don't you allow them to express them and to formulate part of that long-term improvement plan?
Well, in a sense, I'm going to use consultation in two different ways because they have different purposes. The fluoridation consultation is actually very specific, and as with all government, you have government decisions, you often have specific consultations about a particular thing, yes, no, and then the details of it. That's not what you're asking about. That's not a fundamental thing. The 10-year plan system is the other kind of consultation, which is what you're asking, which is a mechanism by which the general public can feed their ideas into government. They're not given a yes-no choice or a very restricted set of choices. They're actually asked to put their own ideas in. That is currently in play, and people should absolutely use that mechanism to put to government ideas, however radical and however fundamental, to government about how they should be rethinking this, because that was the whole point of the mechanism that the ministers have currently got for the 10-year forward plan.
That's really helpful. Thank you. Lloyd Hatton, please.
Thank you, Chair. I should start by saying I welcome that the new government has put in this pledge to try and have 700,000 additional urgent dental appointments available on the National Health Service. I suppose my concern there is, and again, I had a constituent get in touch saying to me, it's shocking. The only way I can get any treatment on the NHS as it stands is to wait to be an emergency and then get seen as a one-off. If I was able to get my regular checkup, I could get preventative care early on, and I'd be able to save the NHS a lot of money and myself from enduring a lot of pain. So I suppose my main concern is, it's great we've got this pledge to have a 700,000 additional appointments. How do we make sure they are genuinely used by those with a dental emergency, but actually that those who shouldn't be using up those appointments are getting their care elsewhere?
Yeah, well, so I think we will be very clear in the way we define what urgent care means, and in fact we already have a working definition. It's been developed. There's already a published urgent care standard, which we're looking at again in the context of the new manifesto commitment and the work that's happening at the moment. We will not be counting usual kind of business as usual activity, ongoing checkups as part of these appointments. It's really important, and it's exactly what the government has asked for, that these are reserved for people who absolutely have an urgent need. We do want to take the opportunity to, having learned from some of the places that are doing this already, and there's a lot of experience out there. I think we've already mentioned London and Manchester as examples, but there's a number of others where they've looked at different ways of identifying precisely who that urgent cohort is, and we would like to make sure that we are as clear as possible that is consistent across the country in the way that this rolls out. But we absolutely cannot be counting appointments that are for an ongoing care plan for a patient as an urgent appointment.
Okay, thank you. I suppose, I imagine this will speak very much to Rachel's constituents as well as mine. How do we make sure that those areas where there is very, very little capacity, and that actually those are the places that get their fair share, which will inevitably be more, and therefore a priority of the 700,000 additional urgent dental appointments?
Yes, so the conversations that we have had with government already about how we would make this work, and obviously it's not been finalised yet, there's still an announcement to come, but we have recommended taking into account there's a number of different measures of need, and we're also looking at under delivery on existing contractors as well. So that means that where we've already got poor access in different parts of the country, we will make sure that those areas are prioritised for the additional urgent care appointments. So that will be taken into account in the way we roll this out.
And a final point, it's the right aspiration, and I think the government made this very, very early on, and they've spoken a great deal about dentistry since the election, and indeed the front bench did before the election as well. But could you go into a bit more detail about the time frame for delivery of the additional 700,000 urgent appointments?
Well, I think we clearly there hasn't yet been an announcement of it. We've been doing some early work with our commissioners, learning from what was out there already to prepare for making really rapid progress on this. We've already put it in the planning guidance this year. It's going to be one of the key priorities we're holding ICBs to account on. We will be obviously talking to them in a lot of detail about this shortly to understand to make sure we're clear on what targets there are and how quickly to achieve them.
Thank you.
All done? Any more questions from anybody? So, this is only the beginning of this committee's journey on this subject. We will be going along the journey with all of you because we desperately want to see an improvement in dentistry service for our constituents. So the next opportunity we will have to examine this is our hearing into the DHSC annual report and accounts, when no doubt, hopefully, Professor Sir Chris and you and Manager Pritchard will be joining us. Just to give you fair warning, I think one of the subjects which will be interesting to the committee on that occasion is the increasing costs of NHS clinical negligence, particularly in view of the dreadful story today of the Nottinghamshire Health Trust and natal care. So that will be an interesting session where we will be able to no doubt cover a lot of subjects, but no doubt maybe dentistry will feature in that hearing. So can I thank our witnesses very much today. I think we've gone over a lot of ground, we've got a lot of answers, and I thank some good candid answers. So can I thank all of our witnesses today for attending. An uncorrected transcript of this hearing will be published on the committee's website in the coming days, and the committee will consider the evidence provided, and we will produce a report with recommendations in due course.